here present, colleagues from hospitals, referral hospitals, teaching hospitals, colleagues from partners organizations. I see many in the rooms that are making effort to be able to work with us in our efforts against antimicrobial resistance. So thank you very much again for being here. Distinguished also other representatives from the other institutions like University of Rwanda, academia, but also other institutions that are present in the room. Esteemed guests, ladies and gentlemen, colleagues, students, and also other stakeholders who are interested in the fight against antimicrobial resistance. And thanks also to other collaborators from Europe, from UK, for being with us. So good morning again. Bonjour, muramutse. Morning. So again, as I said, it's really a pleasure to welcome you all to this significant event, which I think is making the World Antimicrobial Resistance Awareness Week under the theme which is educate, advocate, but also act now. And I think this is really a theme that reflects the status of the gaps that we have today, but also is calling us to really continue to advocate, but also making sure that we act now, if not yesterday, to be able to tackle these threats. It's also an honor to address you today as we unite to confront one of the most pressing global health threats of our time. And also, this week is not just a time to observe, but a very powerful reminder for all of us to come together into this fight. 35 million deaths globally by 2050, which I think is equivalent to approximately 3 deaths every minute. If you compare the thing that is really waiting for us, if not, no action is done today. So we're going to really have 3 deaths every minute. I think we also know that the impact is not only on human health, but also on livestock productions, specifically in low-income countries, where, again, we predict a decline of 11% of the livestock productions if we still to see this increase on antimicrobial resistance. Again, if you understand very well, this threatens food security, which I think is also another issue in our settings, but also the livelihoods of millions who depends on agriculture. So again, if you consider, again, by 2030, the global healthcare expenses could also again rise by more than 400 millions annually. More than 400 billions, and also affecting the productivity losses, which I think could also reach more than 400 billions. And thus again, if you consider all those impacts, we also have another issue with our GDP, which I think is going to also lose around amount of 1 trillion to 3 trillion if we don't do something today. But we all know that evidences also suggest that if we all come together and reduce antimicrobial use in animal specifically, but also in human, we'll be able to probably increase our GDP by 2020 around 14 billions if we really are able to reduce 30% of misuse of antibiotics within animal sector. So this is one of the good news that I think is there for us to act and also be able to continue to reduce the use of antimicrobial use in different settings, specifically in animal sector. So Rwanda is not left from this impact. So in Rwanda, we know that there is also a rising burden of resistant infections, including also many infections that we see in our clinics, like bloodstream infections that we see in most of our referral hospitals, where most of the patients who have been put on irrational antibiotics are seen at those hospitals with high risk of dying from bloodstream infections because of no available solutions or antibiotics to treat them. And then also, if you consider other serious infections like malaria, today we are seeing rising of malaria in Rwanda, which could also probably be due to some of the resistance that we see to anti-malaria drug that we use in Rwanda. I would not forget to mention about tuberculosis also. I think we have made tremendous impact to control tuberculosis, which are still killing. Is also ranking among one of the top infections that kill our populations. And then if you consider what is killing them, again, multi-drug resistance tuberculosis also among issues that we see for tuberculosis. HIV also the same. So again, if we don't really act now, we are going to see a lot of issues, many infections which are left not treated because we don't have left antibiotics which are still effective against those pathogens. So again, the threat posed by antimicrobial resistance, again, transcends borders and sectors. As we have mentioned, it's about impact on human health, food security, and also the environment. So today, we are very honored and we will have the opportunity to launch our second national action plan for antimicrobial resistance, version 2, which I think is another commitment and the determinations that Rwanda is bringing on the global fight against malaria, against antimicrobial resistance, to really strengthen another aspect of multi-sector response, which ensure that we have that resilience. This is across all the One Health spectrum, as I mentioned, animal, human, but also environmental. So again, we all know that this urgency is not only something we see with infections. We also see this agency today as we continue to face more outbreaks. We have seen that, for example, during the outbreak of COVID-19 pandemics, COVID and also the Marburg, that we are still coming out of this Marburg outbreak. We can see that some of those patients who are at risk of outbreak are also sometimes require antibiotics, which I think put again another caution on us to continue to really use rationally those antibiotics to avoid bad outcome among those patients who are faced by those outbreaks. Again, we cannot afford to delay our response. Again, I'm convinced that with the launch of our National Action Plan, version 2, I think we also want to say that Rwanda is ready to meet the challenge, but also we are going to make sure that we build also on other commitments, declarations, and efforts that at the global level that is also currently focusing on national actions of antimicrobial resistance. I don't know why I keep bringing malaria, because I think we see that nowadays, I think this is where we see raises of cases due to anti-malaria resistance. Again, we remember that I think last week there was ministerial meetings in Jeddah only focusing on antimicrobial resistance. And then there is also that political declaration that we think that country need to align to make sure that we have this national action plan implemented and also monitored to make sure that we address all those issues of antimicrobial resistance. So again, Rwanda has also made significant strides in combating antimicrobial resistance through this holistic and also collaborative approach, as I mentioned. So for One Health, for us, is again a framework that we are going to continue to use as our multi-sector coordinations to make sure that human, animal, plant, and environmental health are coming together to implement this national action plan. Again, we have also made sure that we have a surveillance system which is very strong and effective to make sure that we monitor and also produce data on antimicrobial resistance, but also antimicrobial use to continue to strengthen also another effort which at the global level where we have the global antimicrobial resistance and use surveillance system, the GLASS, that today Rwanda is able to provide data from that surveillance system, which is very important to ensure that we have evidence-based interventions towards reducing antimicrobial resistance. Another aspect of where Rwanda is also making a lot of effort is universal healthcare coverage, which I think is also going to make sure that we have equitable access to the quality diagnostic but of medicines while promoting our responsibility for the proper and prudent use of antimicrobial across all sectors without forgetting public awareness but also public engagement for them to be aware but also be educated to use efficiently antibiotics. So these achievements, I think, are some of our solid foundations for the next phase of our journey. And also the National Action Plan 2 is going to build on these foundations, which I think is coming with a very well-costed interventions, priorities that we think is going to really make impact and also achieve tangible results in this framework of reducing antibiotics. Again, another aspect of this our effort is that this One Health approach, again, also underscores the critical needs for global collaboration to tackle antimicrobial resistance through that integrated effort that I mentioned. But again, Rwanda will remain committed to its evidence-based and also partnership-driven interventions, which I think is going also to be very important as we continue to strengthen our system to foster innovation, but also build resilience as far as antimicrobial resistance interventions is concerned. So again, collaboration with our partners is going to be very key. So again, IMR as a global challenge is also a thing that if you are not guided by this approach, we will continue to fail on our effort. But again, we want to make sure that Rwanda continue to use all those opportunities to champion the coordinated effort, but also recognize that we are probably not at the right time in terms of really developing actions to really making sure that we reduce the risk of antimicrobial resistance and also its impact. So as we reflect on the progress made and also the work that lies ahead of us, let us all remember that fight against antimicrobial resistance is not just about protecting health systems, it's also about safeguarding the future of our populations, the future of the global planet. I encourage each of you to continue to take today's sessions and activities as serious as possible, contribute to discussions, but also making sure that we are all committed forward to ensure that we continue to educate our stakeholders, we continue to advocate, but also making sure that we act with agencies and also determinations. Finally, I hope that together we can turn the tide against antimicrobial resistance by really preserving the effectiveness of the life-saving antimicrobials for the generation to come, as we know that the more we extend our life expectancies, the more we have a lot of opportunities for treatment, where I think we need to continue to preserve antibiotics. We also know that as of today, our population is faced with non-communicable diseases like cancers. And cancers is also, again another opportunities where we still need to act today to be able to have those available antimicrobial to treat those patients in need of antibiotics. So thank you very much. I'm really glad to open today's conference, and I look forward to productive but also fruitful discussions, but also meaningful deliberations as we celebrate this antimicrobial resistance week for this year. Thank you very much again. Murakoze cyane.
Another round of applause for our DG. Thank you so much for opening this conference. Thank you for highlighting the global and local threat that exists, as well as what Rwanda is doing to mitigate antimicrobial resistance. Thank you so much. So we'll now love to welcome our dance troupe for an opening performance, and then we'll proceed.
Singiza urwabyaye mahama Rwanda rwiza Rwanda rw'imisozi u Rwanda rwacu rw'ibiyaga n'ibirunge bereza buhoro mahanga nimwumve ibyiza by'u Rwanda mahama imirambi myiza y'iwacu shenge amata bateza agatemba we ibibaya bikiri inyange ku mugoroba inyana zitashye mahanga nimwumve ibyiza by'u Rwanda mahama ibiyaga byiza by'iwacu shenge hari ikivuna cyo hawe muhazi yo mu Buganza we ibuganzi burera abana mahama nimwumve ibyiza by'u Rwanda mahama ongera ungabire wararaje ongera ungabire ungabire ngawe ungabe ngamozende iye nyamebwa mwe iye nyamebwa mwe ongera ungabire bihogo Nyame kamwe Nyame kamwe Ongero ngabire Ungabere jana Ungabere bihogo Ungabere ngawe Nyame kamwe Nyame kamwe Ongero ngabire Ungabire mukara Ngabeho Nyame kamwe Nyame kamwe Ongero ngabire Ungabeho Ungabere ngawe Nyame kamwe Nyame kamwe Ongero ngabire Ongero ngabire Ngabere behogo waraye
Rungano warahize Rungano ko wahigiye ngaharambe
Rungano
ntawaguwo bahangana Rungano yamwahanga muhoreke
Rungano
Kaboka rugamba yaraye Rungano intwari yarahatabaye
Rungano
idore Rungano inka zahagira bahangana yeho musambi Rungano ko wahigiye gaharambe Rungano warahize Rungano ko wahigiye roheje
Rungano
Shenja wakobwa muraye Rungano Wichana mukuye
Rungano
Ntawa wabanganaye Rungano yamwahanga muhoreke
Rungano
Kaboka rugamba yaraye Rungano yantwari yarahatabaye
Rungano
dore yaramera aye Rungano oye manga zahaye iyo ni mpagaza y'urwego dore ko iriwe yibuza abagabo bazarinda shegera y'ibyayigira ishema nanone ribena y'urugamba ndagakara kwa munore gakomoka mu barone urwo n'uruhande ry'abagabo barwarinda iyo ni mpagaza y'urwego dore ko yiriwe yibuza abagabo barwarinda shegera y'ibyayigira ishema nanone iyo ni mpagazaga abahungu icyo ni ikibyutse cyerekezaho ko n'agakara ko mu ntore abagabo barwarinda imena y'urugamba gereza aho rwa mugenzi bagabo barwarinda iyo ni mpagaza y'urwego dore ko yiriwe yiboza yarayibyayigira ishema mpagaze y'intego dore ko yiriwe yibonga isagera y'ibyayigirisemo nanone abana bahungu mu Rwanda ko n'inyamibwa z'u Rwanda iyo zateze murekesha n'imena y'urugamba rwakiraga ikiragirire cy'amakuza nanone iyo nimpagazaga abahungu dore ko yiriwe yibonga yarayibyayigira ishema ubwo ni rwakiraga nanone abahungu b'u Rwanda abagabo barwarenga n'imena y'urugamba uwo ni rwamarara rwa murimbanyi nanone uwo ni umugaguzi w'amacumu bagabo barwarenga
ingata za kurekerera urugomba kuko intwari ibyo cyo gutsinda ruhama gasimba n'amamara n'agasenye na wibarukira gutabara twabambe gutabara nakora icumu ryanye n'urugomba n'isusurukije rero ryaragasakaza ku rugamba rw'abahungu b'amari
Wow. Murakoze cyane. Thank you so much to our dancers. Another round of applause, please. Just the energy that we needed this morning. In case someone is not awake, I think that'll do it for us. So thank you so much once again to our wonderful dance troupe. This will now lead to a good segue into the next session of this program. So for right now, we would now like to welcome the WHO country representative, Dr. Brian Chirombo, who is going to deliver his keynote address on a title called Together for a Healthier Future, a unified approach to combating antimicrobial resistance. Please help me to welcome Dr. Brian Chirombo.
Director General of the Rwanda Biomedical Center, on behalf of the Minister of Health, dear development partners, heads of institutions in Rwanda, ladies and gentlemen, colleagues, all protocol observed. Muraho neza. I am honored on behalf of the World Health Organization to give this keynote speech on the commemoration of the World Antimicrobial Resistance Awareness Week. We come together at a very critical time, as we heard from DG of RBC, not only to raise awareness about the dangers of antimicrobial resistance, but also to reflect on our collective responsibility and to renew our commitment to support the work towards antimicrobial resistance as embodied in the National Action Plan on Antimicrobial Resistance, AMR. So I would like to start off by congratulating the government of Rwanda and partners on the launch of the Antimicrobial Resistance National Action Plan 2.0. The theme of this year's World AMR Awareness Week is educate, advocate, act now. This theme highlights the challenge that we face, as we already heard from DG, and the urgent need for unified action. And the best way of doing that, as we also already heard from DG, is using the One Health approach. This week, this conference comes following two very important high-level meetings. The first one, the 2024 United Nations General Assembly, UNGA, high-level meeting on antimicrobial resistance, which was held in New York on the 26th of September of this year. And the second one, which DG referred to, the fourth Global High-Level Ministerial Conference on AMR, which was held in Saudi Arabia just a week ago, 15 to 16 of November, where we were represented by our Honorable Minister. These meetings delivered both political and financial commitments towards AMR. It delivered globally agreed targets and fostered accountability for action on AMR. Because for us to act, we need the whole world to be working together. We need all sectors to be working together. We need a whole of society approach where we work together to be able to achieve these global targets, for us to have the accountability to make sure that action on AMR is actually implemented and would actually yield the results that we need. Because AMR is already one of the silent pandemics. So this year's week is particularly crucial for ensuring that we keep the momentum and continue to mobilize society, mobilize all stakeholders for action, because all sectors have a critical role to play for us to be able to make progress in addressing this silent pandemic. And all countries need to make sure they deliver. And only then would we be able to achieve the commitments that have been made in these two important high-level meetings. I would like to speak a bit on some key points with regards to the theme of the World Antimicrobial Resistance Awareness Week. First, it is really important for us to realize and fully understand that AMR is a global crisis. It's a silent pandemic. Just because it's silent and it's not obvious does not make it any less of a crisis. And it has major impact at local level. So it's a global crisis, but it's not a crisis that we hear about. It's a crisis that almost in every country at the local level, we will feel the negative impact. We are already feeling it, but it's likely that it's going to get worse with time, unless and until we take the necessary urgent action to make sure that we address it together. AMR is one of the most pressing health challenges of our time, because what's happening is bacteria, viruses, fungi, and parasites that some of which we were able to treat and control, are evolving to resist antimicrobials that used to work. It used to be simple to treat some of them. But now it's not only not simple, but it can actually be lethal, where we will have some patients who cannot be treated and will die and are dying as a result. So we're really entering into a very perilous era where what we could do before, we can't do. And it's not just a cost in terms of lives, but the cost which DG was already highlighting some of it. It's going to be very costly to manage. Not just about the health, but also our livelihoods. So globally, AMR for now is already responsible for an estimated 700,000 deaths per year. But the projections, as we already heard from DG, are that by 2050, we may be talking of as many as 20 million people who may die from it. So what it means is we have to act decisively, and we have to act now. Because this is a global crisis that has impact at local level. At local level, we also need to act now to make sure that this is addressed for us where we are. So, as an example, 1 in 5 cases of urinary tract infections caused by E. coli are already exhibiting reduced susceptibility to standard antibiotics, such as ampicillin, cotrimoxazole, and fluoroquinolones. And this was in 2020. So these are the common antibiotics that we have been using. So this is really beginning to make it more and more difficult to treat fairly simple, straightforward infections like UTI. So here in Rwanda, we know that the country has made commendable progress in healthcare. But we can see, as we already heard from DG, its impact is already being seen. We are struggling with infectious diseases, pneumonia, TB. Yes, we've made progress, but we're struggling to get there. Malaria, we have a recent spike in the cases. We know that the studies done here in Rwanda have indicated that we're beginning to see some resistance, some levels of resistance to antimalarials. So we're not just talking about what's happening elsewhere in other countries, but we're talking about what's beginning to affect us here in Rwanda today. So AMR threatens to undo the progress that we have made over the past 2 decades in tackling some of these diseases. For example, when we look at malaria, the amazing progress that the country has made in addressing malaria. Can you imagine us going back to some of those days, I think about a decade ago? The numbers of malaria and the deaths that we're seeing were extremely high. And those are the risks that we're taking. And this will result not only in deaths, but increased hospital stays. The longer it is, the more expensive it will be for the country to be able to treat these conditions. The more we need to use more intensive treatments for more complicated diseases, and the higher will be the cost to the health system. And of course, the higher will be the loss of productivity to individuals. So that's looking at how AMR is a global crisis, but with a very clear and negative local impact. Secondly, for us to implement and address AMR, we need a collaborative approach that fully addresses all the aspects of antimicrobial resistance. And that's why that theme is focusing on education, educate, advocate, advocacy, and acting now. We need action, not action for tomorrow, but action that we have to take today and now. So as we confront AMR, it is clear that no one entity, be it government, be it you as healthcare providers, as researchers, be it policymakers, be it farmers, be it the private sector, educators, environmentalists, community, we need a collaborative, multi-sectoral, and regional approach to adequately address AMR. So basically it has to be a whole of government, whole of society approach. Because it's only through such collaboration that we'll be able to have the necessary impact, the necessary dent, that we'll be able to roll back the negative impact in this pandemic, silent pandemic that we have in AMR. The World Health Organization articulated a global action plan on AMR because it's very clear this is a global crisis that needs to involve all countries, everyone, for us to be able to make a difference. And at the beginning, this strategy had 5 strategic objectives, but it has now been updated to also include the critical component of governance. Because it's not just technical. When we talk about accountability, we have to talk about accountability at the global, regional, country, and local level. And governance has to be part of that process. We have to hold one another accountable for the actions that we should take. Only then would we make sure that all the sectors, all the experts, the whole of community do what they need to do for us to make progress in addressing AMR. This plan is perfectly aligned with this year's theme: educate, advocate, act now. And we can see this is very clearly laid out, and we will hear later the presentation on the National Action Plan against AMR. I'll say a few words about this theme, starting off with educate. So of course, knowledge is the foundation of change. We have to start with knowing the issues, knowing what needs to be done for us to be able to change. So this is why education is the first pillar of our unified approach. We need to continue, therefore, to invest in public education and training for not only health workers. Of course, health workers are very critical because we know who does the prescriptions, who gives the antibiotics, and the other antimicrobials. It is health workers. So it's very key to make sure that health providers are trained, have the skills, have the knowledge, and of course, they change their behavior to make sure that we make a difference. But we also need to educate the general public because they have a critical role to play. And of course, we're not also only talking of health workers and general public, but we're also talking of all the other sectors, public, NGO, private sector, etc. With regards to medical professionals, we really need to target and ensure that training institutions, because if we wait until our health providers come out of training schools and they are beginning to get in the field to work, it's a bit late. You know, one of the big challenges is behaviors are very difficult to change. And after we have gone through the rigorous years of training, usually when we get into the field, we're just focusing on the work, isn't it? It's very difficult to take doctors, nurses who are busy all the time, pharmacists, etc., to try and bring them for training. We do that. But we know that the effect is not as much as we would like. So we really need to start off from training institutions so that our health providers at the time of formation understand the issues, understand their role, understand the latest evidence, appropriate use of antimicrobials is so critical. And of course, we have to make our public aware of the dangers of overuse, of misuse, of self-prescriptions that are not well controlled. However, the issue of AMR is not just about understanding how antibiotics work. It's about understanding how improper use, whether through self-medication, incomplete courses, which is a big problem. I know I'm talking to health providers, researchers. It's very interesting that we are the worst, isn't it? I mean, we are busy encouraging people to make sure that they follow the instructions that we give. But I know that most of the time we don't even follow those instructions because we believe we know. Well, I've responded. There's really no need to finish off the course of this antibiotic or whatever. So it's really very important for everybody to fully understand that, including ourselves, and practice it. I know as a health worker, I know in terms of practice, sometimes we are sometimes the worst actually, in terms of our practices. So to improve the appropriate use, the appropriate treatment and reduce inappropriate use of antibiotics, we as WHO have developed the AWARE, which stands for Access, Watch and Reserve Classification of Antibiotics, so that we can guide the choice of antibiotic, the dose, the route of administration, and the duration of treatment. We also need to educate, and coming to what DG has already emphasized, to educate our farmers and our veterinarians on the proper use of antimicrobials in agriculture, including animal husbandry, where we know globally we've got a big challenge with overuse. And this can lead to transmission of resistant bacteria from animals to humans. So we know Rwanda is on track, on the right track. And we know because Rwanda has implemented community outreach campaigns, which is what is key, really making sure that communities are well informed. But we need to scale up these efforts. And we need to strengthen them. Because it's only through widespread education that we can begin to shift behavior. Of course, we need to do more. We know education on its own is not enough, but it's a beginning. And we need to do all the other interventions, including engaging and involving communities, having engagements with them so that they really understand the issues and they localize the issues, full understanding of the issues, not just somebody coming to tell them, but them beginning to fully understand the impact and the risk and the issues. Second one is on advocate. So AMR is not just a scientific problem, it's a societal problem. And that's why we were saying we need a whole of society approach. It requires political commitment, it requires public awareness, and it requires a lot of financial investments, particularly when the leaders and the policymakers understand that the lack of inaction to AMR has a big financial impact. We will spend much, much more if we don't take action now than we would. And we need also our politicians, the people who make decisions, to realize that it's not a waste of money, but it's actually a very good investment, which will bring a lot of results. So that's why WHO established the WHO AMR Awareness Week to be done yearly. so that we can make sure that we advocate, make sure we mobilize support, we mobilize all societies, we mobilize all stakeholders so that they can come to the party, so that they can come and participate and become part of this work. So we need strong advocacy at the national and international levels. So it's not just something that we have to do at the international level, at the UNGA, at the global ministerial meetings, but it's something that we have to do also at national level. So it's important to make sure that governments integrate AMR into the national health plans. So it's not just supposed to be about a national action plan for AMR, but it needs to be integrated, because the actions that need to be carried out that will make an impact will need to be integrated in the work that we are all doing as we do our work as clinicians, as researchers, as communities, as stakeholders at the different levels. So this means we need to make sure we enact policies and regulations that promote the responsible use of antimicrobials, that promote research of evidence-based infection prevention and control strategies, and ensure equitable access to quality essential medicines. Globally, efforts have been underway for several years, and these are marked by collaborative work of the World Health Organization, the Food and Agriculture Organization, the World Organization of Animal Health, and the United Nations Environmental Program. This is the quadripartite collaboration, and it embodies the One Health approach, which recognizes the interconnections between human, animal, and environmental health. I commend the government of Rwanda through the Ministry of Health for their commitment to addressing AMR, and particularly putting in place the One Health system and approach to make sure that this becomes an entry point to addressing AMR using a multi-sectoral and involvement of all the key stakeholders. However, we must advocate for more investments in One Health approach. We need to do more research. We need to work more on surveillance. I know, congratulations to Rwanda. I know now there's a push for a One Health surveillance system, including genomic surveillance. And I think that's really very good. And I think that's going to become an example for many other countries to follow. But we need to do more. We need to build the capacity of technical people in all key One Health ministries. Should not just be those few ministries we're talking of. Yes, they provide the leadership, agriculture, health, etc., environment, but it needs to involve everybody, including education and other sectors. So we need to advocate for a coordinated response which involves partnerships through all the levels, from the national, regional, district, and local level, involving all civil society, involving all the sectors, private sector, NGOs, academia. We need regional and global commitments for us to be able to essentially tackle AMR, especially for ensuring equitable access to effective treatments for all nations and sharing best practices. And then with regards to the last part, the last pillar, which is acting now. So we can have the knowledge, we can have the strategies, but we need to make sure that we have the appropriate evidence-based action and act now, urgently, and collaboratively. So One Health is central to our fight against AMR. And again, we commend Rwanda for the progress being made in putting in place and operationalizing One Health. Because we know AMR also does not respect borders. So it means our response needs to also not respect borders. And that means we need to see how we work with other countries and how we build capacity. And this is the role that us as international organizations are playing to help this regional approach. So the human, animal, and environmental sectors must work together to reduce antimicrobial use where it is unnecessary. We know that we do need to use antibiotics, antimicrobials in these other sectors. But the key is making sure that it's appropriate use and we reduce unnecessary use. We improve infection prevention across all those sectors, and we support the safe disposal of antibiotics and other antimicrobials so that we prevent contamination of our water systems and the environment. We need to work on improving on water and sanitation and hygiene. Wastewater management needs to be addressed in all sectors because all these are key in preventing infections and reducing the risk of spread of antimicrobial resistance. So through a coordinated approach, we can strengthen our healthcare systems to ensure that rational use of antibiotics and diagnostic capacity is improved. We need to continue to strengthen antimicrobial resistance, antimicrobial use surveillance, and reporting systems so that we can identify resistant strains early and put in place response mechanisms. In the area of strategic information and innovation, WHO has launched the Global Antimicrobial Resistance and Use Surveillance System, GLASS, which started in 2015 to make sure we inform the AMR response in the member states. And we commend the government of Rwanda for always being responsive, and each year they have been responding and ensuring that they provide their input to this important survey. Moreover, we must invest in innovative research and development to discover new antibiotics and alternative therapies. The market for antimicrobial has not been as lucrative as other drug areas because we know infectious diseases are still more common in third world and developing countries and not necessarily in the developed world. And therefore, there's a slow pace of innovation. There's exacerbation of the threat of antimicrobial resistance as a result. And this leaves us with no options than taking immediate action. WHO support priority setting for AMR research and product development, including the WHO bacterial priority pathogens list, to guide research and development into new antimicrobials, diagnostics, and vaccines. Greater innovation and investment are also required in epidemiological and operational research. And in this regard, WHO has outlined 40 priority research topics for AMR in human health. I am happy to report that WHO is working with the Ministry of Health of Rwanda and other partners in planning an AMR survey. And I think Rwanda will be the 6th country in the world and the 2nd in Africa to implement this survey. And we are hoping that the survey will be implemented next year. And we're also working at supporting the government to build capacity in this area. We already have work ongoing we have our national reference lab project, which we're supporting government, where we have been training teams from districts to be able to collect and conduct antimicrobial resistance testing. So we're building on that with this AMR survey to help the country, working with other partners, to continue to build the capacity of the country in the area of AMR testing. So Rwanda is positioned to be a leader in the fight against AMR in Africa and globally. The country has already shown its commitment by updating and developing the National Action Plan on AMR 2.0, on working on strengthening surveillance systems, on building multi-sectoral partnerships. Rwanda is operationalizing, as I mentioned earlier, the One Health approach, and the way the country is doing it is a model for many countries to follow, with One Health being coordinated through the Prime Minister's office centrally, so that all the key sectors and stakeholders are coordinated and all the work that is ongoing. So now is the time to intensify these efforts. We must build on the foundations laid and scale up interventions in all the One Health key players. We must ensure that we are not just reacting to AMR, but also preventing it through improved hygiene, vaccination, infection control. So we have to be using a broader lens in terms of our response. And as we move forward, WHO stands ready to continue to support Rwanda and all countries in the fight against AMR. Our commitment to support Rwanda's health initiatives remains steadfast as we work to prevent the rise of resistant infections and AMR in general, and secure the health of future generations. In conclusion, AMR is a global challenge. It's a global crisis that has massive negative impacts at the local level. It requires a collaborative, multi-sectoral approach using the One Health approach through educating individuals, communities, healthcare providers, and advocating for stronger policies and taking decisive action. We can combat the tide of AMR. I encourage you all today, whether you're policymakers, government officials, health providers, farmers, researchers, advocates, to embrace the theme of this year's World AMR Awareness Week. Educate, advocate, act now. This is our collective responsibility. And this is how we will protect the health of our communities now and the health of future generations. Together, let us overcome antimicrobial resistance. Together, we can ensure that modern medicine's ability to treat infections remains available no matter where we live. DG, colleagues, ladies and gentlemen, I thank you.
Thank you. Thank you so much to Dr. Chirombo. Another round of applause for him. Thank you. All right. That was a very nice and thorough keynote. keynote speech. Thank you so much for emphasizing the need to pretty much leave no one behind when it comes to the response, when it comes to One Health and coordinated response. Those were very insightful remarks. We thank you very much, WHO country representative. And this is now a good segue as well into the next segment of our presentation. But maybe before we move forward, if you allow, I think we can do a little stretch. Just get the blood flowing a little bit. It's a small habit we're slowly cultivating. So I'll ask you to please stand. Thank you so much. I'll need a very active volunteer to help us with the stretch. How about, where's Gashego? Gashego can come lead us in this stretch. Please, come. All right, let's welcome Gashego up. Gashego, could you come up? He's too busy coordinating everything, but he could probably use a stretch as well. Yay, a round of applause for Gashego. All right. Take us through an energizing stretch.
Thank you. Let us do like this. Let us move down. Yeah. You go back. All right. Thank you.
Thank you. Thank you, Gashego. Thank you so much. Although it was very short, but I guess it was straight to the point. Okay. So, distinguished guests, we're now segueing into our presentation on the AMR National Plan, National Action Plan 2.0. This is one of the highlights of this event. So, please help me to welcome our Director General of RBC, who is going to walk us through this important presentation. Dr. Claude Mouvigny, you're most welcome back. And then if we can project the slides, there we
are. Thank you very much, the moderator, and also thanks to WHO representative for the powerful message, but also good call for actions, but also for more collaboration. So thank you very much. So I'm going to really making sure that I don't take much of your time. This is a work that was done through a collaborative process, not only mentioning the quadruple or the tripartite One Health framework or processes, but also our partners who are still with us in this room today to make sure that we continue to have a national action plan which reflects the gaps but also opportunities for all of us to put what we say today into actions. So I'm going to take you through brief presentations on what are the issues now, the gaps in terms of the global efforts to have a national action plan on IMR available in country. This is one. Second, how do we also put in implementations that national action plans? What are the opportunities? What are the gaps in terms of making sure that we continue to implement what we have developed? Last but not least, this is a plan that needs to be revised, first of all, to be monitored, revised, and making sure that we do have it improved as we face different issues in terms of implementations. So again, so if you consider at global level, this is an assessment that was done 2 years ago where there was an assessment to understand how many countries or regions are able to have a national action plan on IMR. If you can see in these slides, We, in 2022, where we see, for example, in Africa, only 34 countries had national action plans available, developed, to be implemented. And then Rwanda, fortunately, was among those countries because our first national action plan was published in 2020 and then expire this year. So again, this is, another proof or evidence that we still have to not only keep this awareness week in saying it, but also making sure that we really act also in different ways in terms of making sure that we have this action plan. Again, if you consider our first national action plans, again, this was our first national action plans. Again, we were able to make sure that by relying on the strong political commitments, it was very easy to convince, but also start the process of developing these action plans, despite the challenges that we had at that time, without forgetting also the COVID and the pandemic. So again, the political commitment was very important as an enabler of us starting to have our first national action plan on IMR. Unfortunately, if we assess ourselves in terms of how did we implement these action plans, you can see that the overall implementations was around 34%, which I think is another gaps that we have realized. I think has allowed to really address those issues of implementations. Awareness, you can see awareness. I think one of the good lessons from this first national action plan is that the governance was actually well implemented. We had a framework on having technical working groups available. The laws were there, the policies were there. That is why you see that this governance component or framework of component was really implemented at that level. And if you compare practices, I think we still had a very big challenges in terms of making sure that what we have in our action plans is put in practices. We will see later how this was challenging. So again, considering these low implementation challenges, we came back again and say, how do we, at the same time as we are developing the new ones, maybe let's make sure that we have very clear activities, very clear messages within the new revised action plans to make sure that we improve the implementations, but at the same time also we continue to have this commitment on things that we didn't do very well. Again, if you compare some of the domains that has to be available within the objectives of the national action plans, we can see that if you compare all those action plans that were published, that were reviewed in that assessment, you can see that the areas of technology for optimized antimicrobial prescriptions and use, I think, is still lagging behind, as you can see in all regions where, for example, if you compare the least developed countries where only 31% of the action plans had a good component focusing on optimized antimicrobial prescriptions and use. Another area that was still suffering is around culture and how do we address the behavior and culture of populations where those action plans is going to be implemented in terms of really making sure that we understand the social drivers of implementing the action plans. The other area, which I think is also very important to continue to put much effort, is patient and public engagement in terms of really making sure that we involve that stakeholders, which is communities, how to make sure that they are also part of the process. So I think you can see some of the domains were there, but others were still not really clearly mentioned in most of the action plan revised at that time. In terms of gaps, again, in those national action plans and opportunities, as you can see, for example, for the policy and strategic planning, I think for us, we had this political commitment to make sure that we have our commitment. But again, if you see in other countries, there is still gaps in making sure that there is an evidence of political commitment, which was not there in terms of how to make sure that we really bring that multi-sector collaborations and also the one-net approach, the governments, and how do you have those technical groups to allow this action plan to be made. And then there are a lot of opportunities to improve, and it's really very important to make sure that we enforce the implementation of an action plan, but also ensuring that there is a framework within which the national action plan is going to be implemented. If you consider medicine management, I think there's also another issue in the supply chains for antibiotics. Thanks to Rwanda, with a very strong supply system, we still have few challenges in terms of making sure that we have good antibiotics available and also used by communities. But if you compare other countries, you see a lot of issues around how do you make sure that we really have essential medicines list, for example, available within facilities. How do you make sure that we also monitor the use of prescriptions within the clinical facilities so that we really assess what are the antibiotics which are available, which ones are not there in terms of really the availability. Again, the cost is also another important component of really gaps, but of course, there is still opportunity to making sure that we have local productions of antibiotics. This is something also Rwanda is also putting in front in terms of availing those antibiotics. Again, in round of technology and diagnostic, again, how do you make sure that we have rapid tests available for early detection of diseases, to prevent disease to continue, be treated late, and then give opportunity to pathogens to continue to become resistant. Again, information, as WR mentions, is very, very important. How do we collect information into our surveillance, but also use them for policy, for guidelines, and so on and so on. One of the major gap, again, is laboratory capacities. I think if you go around most of the DC hospitals, I think you will see there's still some challenges in terms of having capacity infrastructures to allow culture and also antimicrobial susceptibility capacity to be available within those facilities. Again, there are a lot of opportunities. How do we make sure that we introduce simple and also very network-connected diagnostic network to really allow there is access to diagnostic, but also access to really available tools in terms of diagnostic. Patient and public engagements, I mentioned about it. How do we make sure as also we engage our stakeholders, those patients? We educate ourselves, but also educate the patients. How do they take prescriptions the way we want them to take it to avoid antimicrobial resistance? So I've seen that the use of antibiotics, the only biggest thing that we can do, if we are able to reduce the use of antibiotics, we may be able to make a very good impact in terms of antimicrobial resistance. So again, let's continue to organize those education campaigns, but also making sure that we have those strategies on assessing the attitudes, behavior, and also the society. It's not really a one fit for all approach, but again, how do we adapt those educations and campaign based on the population that we are serving? So again, it's very important to use that opportunity also. Last but not least, also again, the behavior. How do we change the behavior of prescribers? Again, we as prescribers also, we have our own behaviors, which I think need to be somehow controlled to those antimicrobial stewardship interventions, where we really regulate, but also monitor how prescribers or doctors are prescribing antibiotics within the clinical facilities. How animal doctors are prescribing antibiotic within animal sectors and then other sectors also. Again, also patient, as I mentioned, the communities, how do we make sure that we also avoid misuse of antibiotics to avoid antimicrobial resistance, but also all the burden of this problem. So I think for the new action plans, we were able to make sure that we, as we are revising the first versions, in the second versions, so we really wanted to make sure that there is involvement using our One Health governance, but also technical groups to make sure that we involve all the sectors. So you can see that, for example, we have those technical groups that were available to make sure that there is each one, all the sectors available to the process. The One Health approach that we mentioned earlier, but also how do we raise also the participation and also participation of other sectors like the plant health and the environmental health, which I think for us is still an area which needs more involvement, more awareness to have them part of the process. So again, the second one is that we didn't have a very strong M&E framework in the first action plan. For this time, we really have a very strong M&E framework, which is going to really making us accountable, but also allowing us to really monitor as we implement these new action plans. The costing. I'm not sure that we had a comprehensive methodology for the first action plan, but at these times we're able to use some of the tools, which I think will really give us the confidence that we have the right cost, but also the right interventions, which is really there to advocate for really findings. Again, it's a very good opportunity also to really ensure you that when it comes to advocacy and resource mobilizations, it's again another confidence that those activities need to be there, they are cost effective, and also they need to be seen as an investment rather than cost, as we use a very good tool to assess it. The governments, I think, in the first action plan, we didn't have any clear objective around governance, but this time we will see that the National Action Plan has a really clear objective around governance, and how does governance means in terms of this National Action Plan. The process, I think I don't want to go into the details of the process, but as you can see there, we had different workshops where they were able, the team, all the sectors and also the partners were able to prioritize interventions, and also after prioritization of the interventions, they were able to work on the activities and making sure that those activities are linked with the M&E framework that I mentioned. And also the last workshop was very important to use that new tools and also cost all the activities to be able to have a very, not only an action plan, but an action plan with an operation plan, but also with a very costed activities. So this is how we really progress to get a very strong, which I think for me is a very strong national action plans, which is going to really make a great impact if we take care of the next step. You can see, for example, those are the workshops that were organized thanks to all the sectors, the participants, which I think without them we could not be able to reach the level where today we have a very strong national action plans. Again, you can see the human health is still the most represented, but we want to see more involvement of animal and plant sector. We are there to support them. We'll work together to continue to address that involvement of other sectors and environmental also. Next, please. The budget, I think, is very important. Yes, to having a national plan is good, but how do we implement if you don't have resources, if you don't have available budgets? Again, if you see the component of, and also the sector where the amount is needed. We can see the different sectors with available resources. As you can see, Rwanda Agriculture Board and Rwanda Biomedical Center, again, is where most of the costs are situated, but also other institutions, but also other areas where we think is also a number which want to really be also funded. In terms of strategic objectives with fundings, again, you can see these are the categorization of fundings, which I think this is only numbers, but we hope that we are going to reach out to our partners, to our private sectors, to be able to continue to ensure that whatever we are planning, we also think about antimicrobial resistance. And those costs for me, as I mentioned, are not a cost, are investment. So if you invest in this amount of around 40 billions, I think for us, we are going to make a great investment in terms of saving in other programs that we have within our interventions, our public health. For next year, we need around 6 billion of Rwandans. So where do you get those figures? Again, the time is now. We want to start it by January. If you don't have that available resources, we may not be able to implement this. And we don't want to delay. As you say, today we have to act now. So let's make it maybe work together to really ensure that that's resources and available for us to continue to implement those actions. Again, this is the draft to make sure to really ensure you that we have the action plans. Unfortunately, today we're not able to obtain all the signatures and also print it. But again, as a next step, today I think we are glad to launch it officially as a draft, which is ready to be used. And the next step will be to mobilize resources domestically, but also with our partners together, as we used to do in other areas of interventions. And I think this is something we want to, again, use opportunities of all the other fundings as we are planning, for example, for the pandemic funds that we received. The other also opportunities that I think we need to probably making sure that we start addressing some of the activities of these national action plans. Again, the advocacy implementation is also priority activities will remain there. We make sure that now we came back next year during the same times, during the antimicrobial awareness weeks, where we are happy to implement most of those activities. Again, priority activities, but also monitoring all the activity will be very key. Again, we will continue to advocate with convictions that, of course, the participation of all sector need to be there, not only in the development, but also towards the implementation of these action plans. So again, I just want to finish these brief presentations by really conveying our gratitude and also appreciations to all our partners who are here in this room, who have also contributed to this day, but also other partners who are continuing to support us in all our interventions, including also antimicrobial resistance. And also, we also call for new partners in this area. So I want to finish also by saying, let's continue to educate ourselves, educate others, advocate with for convictions, but also act with urgency. So thank you very much for your attention.
All right. Are we ready for the group photo yet? Or we can do that? Okay, I think we can do that next. Okay. So thank you very much once again, DG Claude, for the thorough presentation on this action plan and especially the urgency to act now, to support now, and to work together to make the action plan happen. So our next guest on stage, if you allow me to just briefly introduce him, is Professor Green, and he's going to moderate the next panel. Our moderator is an associate clinical professor and consultant physician in infectious diseases at the University of Birmingham, as well as a practicing physician within the NHS. And he reminded me today it's not the Birmingham in the US, it's in the UK. So his significant academic work includes leading pioneering clinical trials at the University of Oxford for viral vectored vaccine technology targeting RSV. He has contributed to about 150 peer-reviewed scientific papers, and his extensive work was also pivotal during the COVID-19 pandemic, contributing to the rapid development of vaccines. Currently, Dr. Green is actively involved in developing new vaccine technologies and novel diagnostics, focusing on their delivery and impact on global health and climate change. His projects aim to mitigate emergent health threats and address the broader implications of climate change on public health infrastructure. So thank you so much, Dr. Green, for joining us all the way from the UK. You can now take over the next panel.
And thank you very much. A very kind introduction. It's lovely to be able to join you all today. So, and a special thank you to the Director General of RBC, a special thank you to the many representation of major international bodies that are going to be needed against this global and forever silent pandemic. And of course, a special thank you to everyone here as esteemed guests of this very special event. So it's a very pivotal problem that we all face, and you've heard the theme, educate, advocate, and to act now. Of course, we should have acted yesterday and the day before. It's not very good PR to say we should have acted yesterday, so let's focus on act now being the motto for every day until we start seeing some real change and the benefit to all members of society on this. So as we move through the week and we deepen our understanding of what AMR is, what the potential solutions could be across all key stakeholders, this burden is global but especially acute in the African continent, and it affects not just health but livelihood and future security for everyone. So it's my pleasure to host the first plenary session, which will focus on key stakeholders. And as much as I could talk about AMR, you're not really here to talk to me. We've got an all-star cast, and it's my pleasure to start introducing our panelists to come and join me up on the stage. So first, without further ado, can I please invite Dr. Kandine Tranyok, the Monitoring and Evaluation Officer at WHO Rwanda, who is a medical doctor who has specialized in public health and health systems, with over 18 years of experience in health implementation and data systems in Rwanda and the African region. So please, Dr. Kandine, if you can join me. We're also joined by Dr. Cynthia Mufuranziza, and I apologize if I didn't quite pronounce that perfectly, but Dr. Cynthia is a medical doctor and a public health specialist with more than a decade of public health experience and works both in local and international organizations and has a degree in medicine and a master's in public health. She has a huge, extensive experience in developing guidelines and standards and capacity building in both healthcare providers, monitoring programs, and other helpful agencies related to the HSS agenda. She's currently the Director of Health System Strengthening at Partners in Health and is involved in public health and antimicrobial resistance initiatives. Her work focuses on the surveillance in addressing AMR, and as part of her role, she continues to develop capacity building programs and policy advocacy to strengthen AMR surveillance and response frameworks. Additionally, she collaborates with local and international stakeholders to implement evidence-based interventions to combat AMR effectively. So Dr. Cynthia, thank you for joining me as well. Next, we have Minaz Ajmal Paracha, Senior Advisor and Policy Expert to the Food and Agriculture Organization, or FAO, in Rwanda, With a Master's in Agriculture and 18 years of experience in program management, research and policy analysis, Mrs. Panacha specializes in integrating agricultural and food security initiatives with public health agencies, including AMR. Her work at the FAO emphasizes sustainable practices, robust coordination and partnerships, as well as advocacy and campaigning to enhance global health outcomes. So please, thank you, Ms. Minaz Panacha. Thank you. We have a important substitution. Thank you very much for standing in for us. Next, we have my pleasure is to welcome Noella Umuluziza from JPEGO. We welcome Dr. Noella, who's a Global Health Security and Malaria Director for USAID Tubedo Project at JPEGO. Dr. Umuluziza is a medical doctor with a Master's of Science in Field Epidemiology and Laboratory Training and is currently pursuing her PhD. With over a decade experience in the health sector of Rwanda and the region, she brings deep expertise in malaria, community health, neglected tropical diseases, and outbreak response. And her work reflects the committed strengthening of health systems, eliminating malaria, and advancing global health security. So thank you, Dr. Noella. And last but by no means least, last but not least, is Mrs. Alija Ningwije. So Mrs. Alida is an Associate Director leading infectious diseases programs at the Clinton Health Access Initiative, or CHI for short. And Ms. Ningwije is a public health specialist with over 10 years experience in the public health sector and holds a master's degree in international public health from the University of Sydney and a bachelor's degree in biotechnology. And throughout her career, she has worked in various roles across the public and private sectors, contributing significantly to the field of infectious diseases. So thank you very much. So, an all-star cast, I will ask a few questions. Hopefully there will be time for you to ask any additional questions. We will run a little bit into lunch, but not too far. So I'll not waste time and ask the first question and see who is keen to issue a response to the question around how stakeholder engagement can be optimized in AMR initiatives and what are the best practices for maintaining active involvement from all sectors. Thank you. Thank you.
Yeah. Thank you. Yeah, this is a good question, and today with our theme of advocate, educate, and act now. This is very important to have all stakeholders engaged, and optimizing their engagement need a coordinated, inclusive, and sustained approach. Coordinated because we need to have the key stakeholders in all sectors coordinated by the top level, at the national level, to have the implementation of key strategies to address AMR. We need to have a coordination at regional level because, as the WHO representative stated sometimes in the morning, AMR does not have borders. We need to have the countries in the region involved and engaged to implement
evidence-based strategies to tackle AMR, the fight against AMR. We need to have an inclusive approach. This means that all sectors, human health, animal health, agriculture, environmental sectors represented. Yes, they have been there for the development of this National Action Plan, and they have to be there during the implementation. Today, I'm happy to see that we have all those 4 logos there. That means that this is maybe not the beginning, but an improved, an enhanced commitment of all those institutions representing the sectors in the AMR. We also need a sustained approach to address AMR in terms of capacity building of the healthcare providers, capacity building of farmers, and our community. In terms of resources, national resources to tackle and address AMR gaps that have been identified, and the engagement of the private sector. We need to engage the private sector to be involved in addressing AMR issues to ensure that we move forward with sustained measures. Thank you.
Thank you, Dr. Cynthia. Any other comments from any other members of the panel? And my colleague from FAO, I'm afraid you'll have to introduce yourself.
So thank you very much. Well. It's very hard to replace someone at the last minute, but I hope I will make it. I'm Richard Habimana, working at FAO as a AMR specialist under Center of Emergence of Transboundary Animal Diseases. And to respond to the first question, which is very simple to me, to optimize this stakeholder engagement, we have to have like a conference like this. I want to remind you that this is the very first conference on AMR, which is bring together all stakeholders to think together and to plan together. Partners are available, are there, money are there. What the government of Rwanda has to do is to engage actively and participatory all key partners to think together, to plan together, and even during implementation, partners should put the money to help the government of Rwanda to have tangible results in terms of having a robust surveillance system to fight against AMR, which is a next pandemic from the literature. Thank you very much.
Thank you very much. Thank you very much indeed. So it sounds like this conference is already a very key component in bringing key stakeholders together, but this is everybody's problem. So my next question to anyone on the panel today is, when you consider a One Health approach, what challenges and opportunities do you foresee in integrating the human, animal and environmental health sectors to combat AMR more effectively? And please feel free to use examples or anything else that's worked before.
I can take that one. Thank you. So before starting responding to the question, I would like to really congratulate the Ministry of Health and the Rwanda Biomedical Center for the tremendous progress combating antimicrobial resistance. I think one of the challenges we are facing is we talked about collaboration, but we really have competing or differing priorities among sectors. As an example, we can give the fact that for human health, we use antibiotics to fight infections.
While for the agriculture, they use antibiotics to maximize the production of food. So we need to definitely sit together and develop policies together. I think we have started this with the One Health approach. The other challenge is resource constraint. We talk about it, the funding. We, in my organization, we are implementing some AMR activities. I'm saying some, not a lot, because we don't have a lot of money. So this is a problem that you face everywhere. When it comes to AMR, we don't have a lot of money. And it's difficult, actually, to align the priorities and the activities. So policies need to be in place so that we are getting money to respond together to this threat. The other challenge is capacity building. I think Professor Mambo and the WHO country representative talked about this a lot. There's a need of capacity building. We are not building capacity of the healthcare providers only, but also the pharmacists, the people from the animal health, from the environment. But sometimes we tend to forget that we have low-hanging fruits that we can use. We need to educate our population. We know about malaria. A lot of money is being invested in malaria. We responded to Marburg with a lot of money. We have TB. We know very well to protect ourselves from HIV. We need to use condoms and have certain behaviors. But our population, they are not educated. They don't know about antimicrobial resistance. So the challenges is the funding, but also the education. We need to educate. We need to build the capacity of healthcare providers, of pharmacists. I see the room is really full of private and pharmacists from the public sector. Are they really educated? Are they empowered to know what to do to prevent antimicrobial resistance? I think this is what I respond to the question.
Yeah, I could add, Noel, I think you covered most of what I wanted to say. As WHO reminded, really the One Health approach is the only approach we have, whether we want it or not. This is the way to go. But what I've seen, at least with the time we've spent trying to respond to AMR, we do not know the stakeholders, or we do not know all of them. So I think we need to start from there to understand who is on the table and what is everyone bringing on the table and what is their stake in the implementation of what we are talking about. So I think One Health will only operate if every member of the One Health response is engaged. So this comes with its own challenges, and I think that's what Dr. Noela was mentioning, that every sector has its own agenda, its own funding, its own priorities. So having everyone convincing, each other to sit and work on the same agenda is going to be hard. But I think some of the practical ways that could work is to at least sit and agree on a set of common interests and common engagement. Because, for example, if we need to share data, right? We have data from the human, from animal, from environment, but who controls that whole system? We've been discussing this, who's the owner of the system? And then everyone is feeding the system, right? So I think it's important to understand that, okay, I'm bringing in this. You don't have to have everything that comes from the agriculture sector, but you need to have what you need to respond. Same for the environment, same for the human sector. We put together what is important to inform us. So I think we definitely have to find a common understanding and common ground, but also common funding if possible. Because so far, the sources of funding are different depending on the sector. But we need to start creating platforms where we can apply for the same funding for one response. I think Pandemic Fund is an example of some of those fundings. But this needs to continue so that as we respond, we do it in a mindset of One Health, but also the policies and the funding behind supports the mindset. Over to you, Director.
Thank you, both of you. And I think that was very well put, especially the idea that One Health is the challenge, whether you like it or not. And we're not going to fix it unless we recognise it as being one challenge. But I think one of the issues also with stakeholders is finding those win-win connections so that you work collaboratively. And of course, we are missing a major stakeholder on the panel, which is the public. So I think that was very well put. Thank you. But in considering policy, which is how you finished, policy changes often drive significant progress in health initiatives. But what policy changes do you think will drive similar initiatives in response to AMR nationally and internationally? Over to you. Thank you. What we're looking for is any key policy that you've heard in a national action plan, success from the past, opportunities in the next national action plan, that you think is going to be something that will actually transform AMR activity.
Yeah, I think there are policies that need to be developed, but there are policies that need to be enforced, right? There are some that we've been having for a long time, but you can't see the product, you can't see the implementation. So when it comes to new policies, to policies to be enforced, of course, we've been talking about it, the prescription, the use of antibiotics. How are we enforcing this? Because the policy is there. The policy is there, country level, regional level, policy is there. Everyone knows about it. But how are we doing it? How are we enforcing it? How are we practically implementing it? So this is not a new one, but it's one that is not being useful. That's why we're talking about all the problems we have today. As I was participating in the workshop to develop the NAP, I had another realization that I think, so we had many partners, and then we had WASAC. WASAC is the Water and Sanitation Corporates. In our technical working groups in the health sector, we never have WASAC, right? When I saw them, I was like, what is the relation? But these are the people who are dealing with the waste that comes from the health facilities and the pharmaceutical settings. And they were very vocal about, being considered when we take these decisions. So there are some policies that are specific to some of the initiative that we have left out. So I think waste management policies have to be either created if we don't have them, or enforced, because as much as we think of facilities and hospitals, what comes out of it is actually the one that is affecting the One Health, the water we drink, the soil we cultivate in. So a policy around that, I think, will be helpful. And initiatives as well, not necessarily a policy. I think we need to start creating initiatives, for example, for a hospital that is doing a good job in management of antimicrobials, like really making people appreciate some of the efforts so that it can awaken the rest of the players as well. Another initiative is about how do we educate. I think Dr. Noeda was mentioning it. Education, how do we educate the population? Because these are the people who go in the pharmacy and buy antibiotics. But do they understand what they are doing, what they are contributing to? Who's there to tell them or to put regulations around that? So I think in Rwanda, at least, we have majority of policies, but enforcement is limited. And I think that's where we need to put efforts.
Thank you very much. In terms of policy, let us have a look at the National Action Plan on MR, the first version. We may have a good policy, a good document, but when it is in terms of implementation, you don't have a good success rate. For instance, for the first version for MR, National Action Plan, the assessment revealed that only 34% of all planned activities were implemented. And you can ask yourself, why another portion, another percentage were left behind. So I think on this question, we can focus much on implementation of the good document we have and try to enforce all stakeholders to be able to have good document and implementation of those policies. Thank you.
Thank you. As previous panelists said, we have already policies and the regulations. They are there in Rwanda and most of the countries. What is needed is their enforcement. Enforcement of antimicrobial use in terms of prescription practices, in terms of use of guidelines, in terms of harmonization of standards in the region. In many countries, we have different standards. In terms of availability of drugs, drugs with respecting standards. This is something important in addressing AMR, as we know that due to sometimes insufficient regulations for enforcement of regulations and the availability and distribution of antimicrobials, we have counterfeit and substandard drugs most of the time in low and middle income countries. So these are important and key regulations that government should enforce, as well as robust surveillance system. Most of the time we have either fragmented surveillance with much focus on health, on human health, and animal or other sector like environmental apart are not, the surveillance is not there. Why? We'll know that sometimes environmental contamination can also be a source of antimicrobial resistance. So briefly, government need to reinforce those existing policies and the regulations, putting more effort in reinforcing them. Thank you.
Just to add very quickly, I think at regional level we should think about cross-border collaboration and initiative. It's actually very important when it comes to antimicrobial resistance. So we need to strengthen, I think in Rwanda we started that, but this needs to be strengthened again. And also when it comes to research at cross-border, but also at international level. One of the things which can help us to respond to antimicrobial resistance, it's also using the right diagnostic, for example. But these expensive diagnostic tools are not very accessible to us. So at international level, they need to advocate, they need to put up a regulation so that these tools and these drugs, actually good quality drugs, are accessible to us. Thank you.
Thank you very much. And it does lead me very nicely on to the next question to all of you, because all of you come from different key stakeholders. You'll have slightly different views on this. But this is very much an evolving problem. It's not the same as it was 10 years ago. It will be different in 10 years from now, hopefully for the better. But what have you seen? And you've mentioned the first National Action Plan, some successes in there. How would you focus on what has worked so far in a way of informing what could be successful going forward as we all take this on together. So Dr. Candine, thank you.
So thank you so much. I think one of the success of the first National Action Plan was that it used the One Health approach, which has been emphasized since this morning with stakeholders' engagement. Maybe, although we had a nice plan, the implementation rate, as my colleague said, as Richard said, was around one-third. One-third of the activities of the National Action Plan had been effectively implemented. One of the reasons was the absence of a monitoring and evaluation framework. So for the second action plan, what we did is to really conduct deep situation analysis to assess the challenges and the gaps and to try to identify some evidence-based actions and interventions. So the plan, the new monitoring and evaluation plan is very well crafted. It has strong indicators with targets. And maybe if I can add, among one of the challenges that we could see from this current plan and maybe the governance structure, the governance has been well planned and there is now One Health Secretariat, but maybe it seems to be a bit understaffed. So we might advocate for more resources for the One Health Secretariat. And once we talk about multi-sectoral approach and One Health approach, I was wondering if having the One Health Secretariat, maybe it has to be like at higher level. It's a high level, but the antimicrobial, team at RBC and the One Health, they might be benefit from let's say, being put at a higher level. But really, there is a need for more resources for the One Health Secretariat. And also about the funding, the plan, as the DG of RBC said, there is still a lot of gap in funding. And maybe we might take the opportunities of some issues which are linked to antimicrobial resistance, like climate change. We know that climate change and antimicrobial resistance, they are very much linked together. We discussed about the issue of malaria drug resistance. With the increase in temperature globally, we might expect an increase in malaria cases, and we are also facing some resistance in the malaria drugs. So maybe we can tap into some, let's say, new avenue for funding the climate change and the pandemics, as my colleagues have said. Thank you.
Thank you.
Maybe quickly to add on what she said, I think the second version, at least seeing how people participated in the development, I think the inclusiveness itself is making a huge difference. It was inclusive, it had every stakeholder, people know what we worked on. I feel like there's more ownership compared to the first one. But also, I think I like the approach we used to prioritize the interventions. Because with One Health, everyone can throw on the table what they think can be done. But how do we go with what is going to work, actually? How do we come up with a priority of intervention? So the exercise was called Smart Choice, I think. So we had to go through the different interventions to see which one are affordable, which ones can work fast, which ones can be deprioritized because of ABC. So I think the exercise helped people to understand what works and what doesn't, or what would work later. So which is going to help us when it comes to implementation to know what we focus on and partners to know what we fundraise for. I think there's more ownership. But when it comes to implementation, I would advise that we start a platform where data is shared. Because if we don't know how things are progressing, everyone goes back to their own agenda. So I think a data sharing platform will be very helpful to different partners who are in this initiative, having really some scientific platform where we share the progress. I think that will be very helpful, but also to clearly state the stake for each one. We call ourselves stakeholders, but some of us don't even know what is our stake, right? So it's good to have it defined. If it's Japaigo, you are working on ABCD. Chai, you're taking this step. And then we meet to debrief and talk about how it's progressing. I think we need to be innovative. Given that the first one did not work, we need to come up with innovative ways to implement the second one, but also give ourselves some timeline to evaluate. I was checking with Dr. Brian if the laboratory has some tools in place that can help us to actually evaluate on a regular basis, and he guided me on how to go with that. But I think for this plan to work, let's know what we have to do, let's share data, and let's have a commitment to regularly update ourselves. Thanks.
Thank you.
Yeah, just for the new NAP or the new action plan, for me, my advice would be to really integrate. We have seen the budget. It's not a small budget, but we have a lot of opportunities out there. We are talking about different outbreaks. We are talking about different diseases. I think we talked about anti-malaria drug resistance, and to combat that, we are making a lot of campaign awareness. We can actually use these platforms to also talk about antimicrobial resistance. We have a lot of supportive supervision that we are conducting at the different facility levels, at health centers, even at community level, because community health workers are treating patients with amoxicillin, for example. We should use these different platforms, the investment that we are putting, mentorship, supportive supervision, the fact that we should also invest in pre-service. We have students, they should be educated. I think for this new NAP, we should really emphasize on integrating, using what is available. Thank you.
Thank you.
Yeah. On top of what my colleagues already talked about, I would add the importance of engaging the community. It is emphasized in this NAP 2.0. We need really to raise awareness on AMR, educate the population for behavior change in regards to responsible use of antimicrobials. We need to discuss this issue and raise awareness among healthcare providers who are the prescribers and who deliver also the antimicrobials, especially antibiotics. We need as well to engage farmers. They are providing antibiotics, which at some extent, again, reach and affect the human health. So all those actors need to be engaged, and it is something that is good and appear very well in this new strategic plan. Another area is the surveillance and reporting across all sectors again. There has been emphasis on the human health with building capacity, building diagnostic capacity and capabilities of lab, but which is not sufficient because we have very few lab able today to report on antimicrobial resistance. So we should have the Sentinel site, existing Sentinel site, able to make that surveillance and to report the resistance patterns, as well as other sectors, animal and environmental sectors as well.
Thank you, and I agree that data is very, very key to this. without data, it's very difficult to be sure of what to action and to measure what your labor has achieved. So I'll ask each of you, we'll just go from Dr. Kandine down, what data are you really missing to make a difference in your AMR problem?
Thank you. So as many have said since this morning, one of the key interventions is to establish a strong AMR surveillance system across all the sectors. So we really need this system in place. And also we mentioned the issue of funding, which should be, let's say, established in a sustainable way. Because even if you have a surveillance system, at the lab level you need the reagents. Most of the time they are not there, so we need to find a sustainable way to get those reagents available on a regular basis. So, but yeah, related to the data, as many have shared, have said, the surveillance system is one of the key interventions that could really change the game.
Thank you. So for you, it's a data system. Okay, thank you. And Dr. Cynthia?
Thank you. At Partners in Health, we are currently working on building the surveillance system, actually supporting the surveillance system with much focus on lab capacity building in terms of human resource and in terms of equipment. Working as well on antimicrobial stewardship. In our hospitals, we have committees, but are not very well functioning due to some constraints, resources constraints in terms of funding and also in terms of human resource, because some people have been appointed but then left those hospitals or have been changed, and they are not well functioning. So they are also in their roles in supporting the hospitals and in supporting healthcare providers. We are also working on infection and prevention and control, which is a very important part of antimicrobial resistance. So we are collaborating with the Ministry of Health and our sites to strengthen infection and prevention and control. Thank you.
Thank you. My next panelist.
Thank you very much. At FO, we are working closely with the One Health platform, which is based at RBC, to support their regular meeting, whereby they are discussing the current status and plan together. We are also working with the Ministry of Agriculture through Rwanda Agriculture Board to strengthen their surveillance system for AMR, whereby we are supporting the digital tool so that at cell level there is someone to report from down up to the ministerial level, and also we train lab personnel and provide some key equipments, reagents, and consumables so that they have a very robust surveillance system for AMR. Thank you.
Thank you very much. Dr. Noella, what
so I think for data, the data that we are missing, that I would like to have, which will orient our interventions, first of all would be the prevalence or the magnitude of AMR in Rwanda per antimicrobial molecules or families. The other one would be the most affected drugs. And the last one would be data on mortality due to AMR. We have seen data for the whole world, but what is the situation of our country?
Thank you.
Yeah, I'll speak from what we've been working on as CHAI. I think we miss lab data. we have gap in understanding the need in terms of what is requested in the lab, which should help to plan, to know the support that is needed, but also the budget that is needed. I think lab data has been missing. Hopefully with this NAP, we'll be able to improve on that. We also, I think the colleague from FAO mentioned it, is we don't have a system to connect those labs. So you may have a report from lab A, but you don't have a report from lab B. Yet you need to see a countrywide report to be able to make your plans in terms of support. So we're working with RBC to come up with a system that could be installed in at least 12 Sentinel sites we have today, so that we can at least understand what's happening in those 12 in a digital way. So I think if we have that, it will be a good start as we scale for including, I mean, we include other labs and maybe other sector, but I think a digital system and lab data is, from our side, what we think was lacking. Of course, the budget was a problem, but I think with this NAP, now it's broken down, it's clear, you know where you can intervene. So I think this one is solved, but we need to continue working on the lab. Yeah, thanks.
Thank you very much. I appreciate that was a slightly difficult question to all of you. So I'd like to know if anybody in the audience has any questions for any of our panel members. So over to you. I think we might just need a microphone for this lady over here. And we have other hands up as well.
Thank you so much. My name is Sifa Florence Sangwa. I have one question, but it is very critical because we know the role of antimicrobials in agriculture practices. Given that most of people who are into agriculture are in the rural villages where they are using antimicrobials without knowing that there is resistance or other consequences about antimicrobial use. So what are the strategies that is being implemented to make sure that those in rural areas and those into agriculture know what is antimicrobial resistance, the consequences, and how, what is the other strategies are being implemented so that antimicrobial use in agricultural settings can be lowered down? Thank you.
For the sake of time, if it's okay, could we collect and then we can go ahead and respond? Okay, maybe like 3 more questions.
Thank you very much. My question is about regulation. We want to know what steps is Rwanda taking to regulate the use of antimicrobials in agriculture, that's for lab, in healthcare, to reduce resistance. Number 2, so did we take, if we want to educate, did we introduce a topic or course units on antimicrobial resistance into the curricula of primary schools or secondary in the philosophy of catch them young? So that we also want to hear from the panelists. Thank you.
Maybe say your name and your organization as well. Your name, organization, ushaka kubazikibaza.
Good morning, everyone. First of all, I'd like to thank the organizers of this assembly for bringing us together to address such critical issues that affect us as healthcare providers. It's a rare opportunity for us to share our experiences and concerns in such forum, and I believe discussions like this are key to moving our profession forward. I deeply appreciate the effort put into making this event happen. My name is Nwadi Dauphin, and I work in a private sector, and my concerns are centered on career path, and I will talk about 3 key points that private sector's healthcare face because of how the structures tend to focus on public sectors. For all these 3 points, I have specific cases and details that can be described. Based on the theme of today, educate, advocate, and act now, I would like to start on a point that private sectors face, which is practicing professionally as private pharmacists or nurses. The private sectors, retail and wholesale, are business-oriented, I can say, and we face challenges when it comes to practicing ethically. Aside from narcotics and some other medications, including antibiotics, are not properly regulated. If a patient walks in, for instance, asking for something, we should give them, because if we choose to be ethical and refuse, the patient will simply go to the next pharmacy. That's the reality. This compromises not only the antimicrobial stewardship, which is part of today's agenda, but also the integrity of our profession. So I would like to say that we should, professionals, how can we establish a system that allow healthcare professionals, especially from the private sectors, to practice ethically, protect public health, and ensure that their licenses are fairly compensated and not misused by the employers? Allow me to escalate my questions, as they said that one of the solutions to educate, advocate, and act now is training the private.
30 more seconds. Okay, it's fine.
Training the healthcare professionals, and as for 3 years I've been practicing, it looks like when you want to try to apply or do a training that would help, you are not selected only for one reason, that would say that you work in a private sector. They just don't think, look about the competency or the passion that healthcare professionals in private sectors have, but they just reject just because you work in private sectors. Thanks.
Thank you. Maybe the last one. Okay, I see only one hand.
Thank you very much. My name is Tope Adegboyega from the Department of Microbiology and Parasitology, University of Rwanda. I actually want to find out the plans of the partners in relation to research for resource mobilization. I was waiting to note this in all that have been mentioned, and perhaps what could also complement what we have listed is for us to be able to embed research into the various human capacity developments at the center. So I want to know 2025 to 2029 in the NAP2, what are the partners' interest in advancing research countrywide? Thank you.
Thank you. Very good and concise. Maybe one last one in the back.
Thank you. I've been given 1 minute, so I would like to ask on the active AMS programs. I would like to direct my question to the lady from PIH. So when you look at the hospital accreditation programs, they only cover IPC, and within IPC they just cover drug-resistant problems. But then would it be more beneficial to have a specific risk area that talks about antimicrobial resistance and also that evaluates AMS programs? You will see that in countries like the UK, you'll see commissioners of AMS who are championing AMS programs across the nation. So do you think this would be a nice strategy in Rwanda? Thank you.
Okay, you can go ahead.
Thank you very much. They were lovely questions, not easily answered, but we only have a few minutes, so I'll invite my panelists to respond to any question that you feel could help in just a few minutes, but then obviously carry on these conversations into lunch. So, to my panelists, which question would you like to try and answer?
I'll take the first one, but I would like also to ask in the room if there is someone who can respond to some of the questions, someone like Rwanda FDA, because we had some questions which, yeah, so I will respond to Sifa, who asked about, it's actually public awareness. In agriculture, our people there at village level, and all of them are actually farming. I think this is something that we learn in the first NAP, and we are putting an emphasis on this, on public awareness in the new NAP. And as I was saying, we definitely need to integrate. We definitely need to educate our people. So at village level, we have platforms, we have umugandas, we have umugoroba w'ababyeyi, we have different platforms that we can use to educate our people. And the journey is not easy, it's a long journey, but definitely we should take benefit of those opportunities and try to educate our people and definitely educate them. You talked about regulation, what is being done. I think I'm not the right person to respond to this question, but definitely we need to emphasize the regulation, and it's also to respond to your questions. Rwanda FDA is here, the Ministry of Health. We definitely need to work on accountability of our people. I think our colleague from the private sector was very honest, talking about ethics, how they sometimes just give the antibiotics to people without prescription. So we need to sit together. Rwanda FDA is here, maybe they can complement, but definitely regulations need to be improved, need to be emphasized, but also a mechanism of making sure that people are following the regulation. Thank you.
I can speak to respond to the gentleman who asked about the research. I will speak from Chai's perspective, but I believe some partners also have maybe flexible funds, but we have, from the pandemic fund, we have some funds we could allocate to AMR research. However, I think the priority is first to build the systems, to make sure that we have systems that can collect data, and then start using the data we have. From there, we can now, because when you don't have data, you can't even advocate for more resources, because you don't have a basis. Mm-hmm. So I think as we work together, and I believe you are, Sehashube, we're working together, we're going to work together on that, and then we can see how we can collaborate on that.
So thank you very much. I want to come back to Sifa questions about awareness in the rural area. As far as FO is concerned, there is a program called the Farmer Field School, whereby we raise awareness of farmers in terms of resistance. And also we used to tell them that if there is no disease, there is no need to use antibiotics. So we educate them to focus on good practices, such as biosecurity measures, prevention, and also not treat viruses using antibiotics, and also not using antibiotics for non-therapeutic usage. Thank you.
Thank you very much.
Thank you. For the question on involving primary and secondary schools in AMR, I think in terms of behavior change, there are some components that can be included depending on the level, depending on which community you are talking to, and for schools, there are of course some components that can be included in their curriculum. Educating children on hand washing is something important, and that can be included in their curriculum, and this will address infection prevention area, including antimicrobial use in the nursing schools and the medical schools is very important. It should start from the pre-service, and so that when they are in the working environment, they know what to do instead of waiting for them to start working and then train them about antimicrobial use. And for the question on private sector, engaging private sector in the area of antimicrobial resistance is very important. He talked about private pharmacies. This is an area that need enforcement of regulations. Regulations are there, policies are there. What is needed is their enforcement. And we hope that the Ministry of Health is here, the Ministry of Agriculture, Environment, and they will be supporting, because today we need to act. That is our theme, and it should drive us during the coming 5 years, and implementation of those regulations is indeed the key, the missing point from previous years. On the question of antimicrobial stewardship program and including them into the current hospital accreditation standard, I will join you and say yes. Hospital accreditation standards are evolving. They can be again reviewed, and including antimicrobial use and consumption in hospitals should be included at some point, because this will help us to control their use and ensure that what is in the regulations at the level of hospital or even health centers, even the community, is being implemented. Thank you.
Yeah, thank you. Just a small comment about two questions on the regulations and the research. For regulations, this is a key area of the new National Action Plan, and some are really needed. Of course, prescribing the use of antibiotics in the pharmacies, including private, but some regulations are also very overdue, and they were needed by yesterday. You can even mention, let's say, the pricing policy for the drugs. So about the question about the career path and training and opportunities for the private sector, I don't know if someone is, we always talk about more engaging the private sector. So maybe it's an opportunity that we need to explore, but also the other way around. In the health sector, we can see that there is a draining of the health workforce from the public to the private. So the privates, I don't think you're the worst placed. And related to research, as our WHO representative said, he mentioned the integration of the policies. As WHO, we supported the National Health Research Agenda, and our representative highlighted at global level, WHO has identified like 14 priorities in the area of research for antimicrobial resistance. But in the National Health Research Agenda, IMR is also taking a big roles and place. And we also put the emphasis on training and capacity building, not only in conducting this high-level research on genomics, and which is of course needed, but even operational research at health facility level to be able to use the data which are already there, even using simple analytics, but to support the implementation and decision-making on a daily basis.
That's great. Thank you very much. You've all managed to contribute some answer, but of course the solution is going to take a lot longer. So I'm conscious of time. I would be grateful if you could show your appreciation for my brave, lovely panel here. Thank you very much, all of you. And I believe, and thank you for your questions and attention. So I believe we are now due some lunch. Is that right?
Yes, in just a second. We have just one last performance, and then we'll take a group picture. We'll go over to lunch. So maybe if the dance team is not ready, should we go ahead and take a picture? A picture? Okay. So I am told we're taking a photo in 2 sections. Let's see, Andrea, are you ready? All right. So if maybe we'll do the first photo, I'll say maybe this table. If you'll just come over to the stage, or at least right here below the stage, we'll take the first picture, and then we'll take a big group photo together. Sorry to put you on the spotlight, but I'm just following the rules. So if you just line up, and the panelists as well, I'll invite the panelists. So the moderator, if you can please join the photo. Wonderful. Can everyone now join on the stage? We'll see how to make this happen. We might need a few chairs, right? Okay. It looks like a good gender balanced picture. We like it. All right, I think we have everyone. Andre, you can go ahead. Beautiful. A round of applause. Thank you. We're going to have just one more performance and then we'll head over to lunch.
Thank you so much, and you're all welcome in this afternoon session. We have few presentations and panel discussion. My name is Ines Uineza, will be the afternoon moderator. Without further ado, let's have NPC chairperson for the first presentation on Code of Ethics for Health Professionals in Antimicrobial Stewardship. You're welcome, sir.
The Director General, Rwanda Medical Center, heads of institutions present here, ladies and gentlemen, distinguished colleagues and guests. It's truly an honor and a privilege to address this esteemed gathering on a matter of critical global importance: antimicrobial resistance. Antimicrobial resistance is not just a clinical or scientific issue. It's a global crisis that threatens the very foundation of modern medicine and public health. Every year, 700,000 lives are lost due to antimicrobial resistance. And if we fail to act, this number could rise to an amazing 10 million by 2050. Economically, the projected cost is estimated to $100 trillion. These statistics, as alarming as they are, represent more than numbers. They reflect the human cost of inaction. This is our challenge, but it's also our opportunity. As health professionals, we are exceptionally positioned to lead this fight. Our actions today will determine whether future generations inherit a world where life-saving medicines remain effective. This is both a privilege and a responsibility, one that demands our commitment, ethical action, and the collaborative efforts. To guide us in this journey, the Code of Ethics for Health Professionals in Antimicrobial Stewardship offers a roadmap grounded in the principles of integrity, accountability, collaboration, and equity. First and foremost, we must commit to ensuring the responsible use of antimicrobials. Antibiotics and antimicrobials are not just medications. They are life-saving resources that require careful management from all health professionals. whether prescribing, dispensing, or administering these medicines, every decision must be grounded in necessity, guided by evidence-based practices, and aimed at preserving the efficacy of these medicines for future patients. Second, we must adopt a broader perspective, recognizing that the misuse of antimicrobial impacts not only individual patients, but also entire communities and the future generations. Responsible stewardship demands that health professionals, whether clinicians, pharmacists, nurses, or veterinarians, consider the broader public health implications of every antimicrobial intervention. Third, we must champion equity in access to medicines. Every person deserves fair access to essential antimicrobials. Ensuring this equity is not only a matter of public health, but also a fundamental issue of social justice and human rights. Fourth, we must embrace accountability in every decision we make. As health professionals across all disciplines, we are custodians of these vital medicines. We must adhere to the highest ethical standards, hold ourselves and each other accountable for the responsible use of antimicrobial in every practice. However, ethics alone are not enough. They must be coupled with action, and that action must be driven by collaboration and unity. Doctors, pharmacists, nurses, veterinarians, and other health professionals must work together in coordinated efforts to uphold antimicrobial management principles. Only through this collective commitment can we effectively combat the growing threat of antimicrobial resistance. Through the One Health approach, which bridges human, animal, and environmental health, we can foster stronger partnership, share knowledge, and implement coordinated strategies. In addition, working in isolation is no longer accurate. Only through collaboration we can overcome this challenge. Equally important, education plays an essential role. Patients must be empowered to understand the proper use of medicines, including when to take them, how much to take, and the importance of completing the full course to ensure effectiveness and prevent resistance. Additionally, advocacy must be a top priority. We must actively engage policymakers to ensure that antimicrobial resistance remain at the forefront of both national and the global agenda. Furthermore, innovation must be central to our efforts. Investments in the new diagnostics, treatments, and vaccines are critical to staying ahead of resistance. Finally, we must recognize that antimicrobial resistance is not just a healthcare challenge, it's a sustainability issue. It directly harms our ability to achieve several Sustainable Development Goals, SDGs, particularly SDG 3, good health and well-being, and SDG number 6, clean water and sanitation. Addressing AMR is essential for building a sustainable and equitable future. Ladies and gentlemen, AMR is a battle that cannot be won by any one profession, country, or organization alone. It demands a united front, steadfast commitment, and ethical leadership. As we move forward, let us remember to lead by example, adhering to the principles of the Code of Ethics in our daily practice, to advocate for policy changes that prioritize antimicrobial resistance as a national and global concern, to educate our communities and empower them to play their part in this fight, to collaborate across profession and borders, because together we are stronger. This is our moment to act, and this is our responsibility to humanity. Let us advocate, educate, and act now against antimicrobial resistance. Thank you.
In his words, misuse of antibiotics affects not only the consumer, but the whole population. He requests doctors, nurses, pharmacists, health professionals to work together to manage the use of antimicrobial for combat against resistance. Educate, advocate, and act now. Join me to thank again Dr. Stanley for the amazing keynote lecture. Let us jump to the second presentation, Antimicrobial and Digital Solution in Rwanda. Help me to welcome Dr. Jibril. You're welcome, sir.
Thank you very much. My name is Jibril Barushimana. I'm a medical doctor with a specialization in anatomical pathology, not microbiology, anatomical pathology, and I'm head of pathology department at University Teaching Hospital of Butare. So I'm going to make a presentation on antimicrobial resistance and digital solution in Rwanda. So I'm not a software engineer by professional, but I have expertise in software development and computer tools or computer science. Sorry. Yes. Good. So, as we are in Awareness Week, I started my presentation with this slide, asking ourselves, but in exclamative way. Were you aware that this publication just mentioned this number of death, cumulative death by this period, 2025 to 2050? So please, I would ask the public or those who are here, those who already read this publication and understood this publication, they read this publication and understood in full, please raise your hand. So please, those who read this publication, so the publication that predicted this number of deaths, so no one. So few of us read about it. Few of us read about it and understood it, yet I think it is the highest impact publication about the burden of antimicrobial resistance. That is, possibly, we are just talking about antimicrobial resistance because others said it, not because we know that it is a problem to us. So it is just responding to other intervention, not to our own feelings. So I call upon everyone to reread, to open it and read about it and understand about it. Maybe it is one of the steps of awareness. Here, we are professionals and we need to understand not to act upon others' interventions, because as far as we don't have this ownership, we are doing nothing. In this publication, the author mentioned about limitations in lower and middle income countries. And I think our country is in L, lower income countries. So these limitations, if you just say or state sentences as the author said them, so it may fill 2 pages. But I summarized them in this sentence. So the low middle income countries as breeding ground for uncontrolled antimicrobial resistance. So this is, we have it, but not controlled. In fact, when someone say that we have it, not controlled, and maybe he's telling us about it, and we act about it, it is not for us, it is for him. It's just to prevent that we can transmit what we have to him, because we don't know that we have it. That is, we stay happy, we stay not scared, yet we are dying. So we don't know that we are dying. So driven by fragmented, inaccurate, and scarce data, that is whatever he found from these regions were not contributive to that number. That is, if really we have numbers that should contribute for real to that number, maybe that number would be even big. That is, our contribution was not reliable. Weak systems, that is, whatever we have as systems are weak, are not responding for real. Poor infrastructure and the absence of equitable, reliable microbiological insight. That is, we are there, just contributing to AMR, and we are not doing anything. We don't know that we have a problem. So we are, turakora sambla comme si we have a problem, then because they say it, not because we feel it, not because we know about it. So I would say, just for this day, that our country must raise beyond these limitations. Even though we are in L, no, we should raise beyond these limitations. Even though we are in L, we don't need to go from lower income country just to prevent death. As it is said, in fact, there is no huge budget to prevent a preventable death. That is, if a person is dying, whatever amount of money you can contribute to not having him dying, this is always less. It it is always minimal money as far as you are contributing to prevent death. Our country must raise beyond this limitation because it is an insult. It is not acceptable. And refuse to ignore deaths in such massive number. In fact, this was my slide for awareness. But, but because everything to know, to recognize that we are dying, we need data. And the data has to be accurate and reliable. So it is where the digital solutions, e-health solutions comes in. So the WHO defined digital health as an umbrella of all art and science of medicine to ubiquitous information. And under this umbrella, there is what we call e-health tool, where all information are generated and are used for communication. So we include healthcare services, health surveillances, health literature, health education, and research in health under the support or supported by ICT, information communication technology. In fact, when we think about data and just improve at the same time while we are proving, we need to think ICT. We need to think e-health, because otherwise we will be thinking in just more analog paper. We will just keep thinking in registry and papers, just having data there that are not contributing to our improvement. So e-health tool that we can think about in our context as a country, we have electronic medical records. In fact, I think in all levels of health care structure in Rwanda, we have electronic medical record. I think we are now even implementing e-health tool at the level of health post. That is, we are no longer in need of registry and papers. We need electronic. But at hospitals, we have AMR that are open source. Open source means that these tools, they are open. Whatever you need to customize to change, you can change it in a minute. In fact, you need to have expertise person just to customize the way you need data, but your data being accurate. These are not licensed, or they are licensed open source. You change them the way you need. These are mainly in public institutions. Also, some private institutions, but all public institutions are using open source tools. But there are institutions that are using proprietary tools. Laboratory information systems, some are integrated in the electronic medical record as modules, but there are some that are separate as standalone, but that are interoperating, or if they are not, they need to interoperate or integrate the electronic medical record. I think nowadays we are implementing what we call health information exchange, just to have a centralized communication system around Rwanda, where one, if he's attending a clinic in Butare and comes in Kigali, all information will be shared at that level. He don't need to have anything repeated. Also, we have health management information system. That is what we call what? Eh? So, but it is based on DHIS2 at country level. Currently, the data we are sending them in terms of clinic are aggregated data. And these data are coming from our electronic medical record, LISs, or they will be coming, data will be coming from the health information exchange. So we have also pharmacy management tools that can capture information on prescription, but also stock control of medication. To our context, that is antimicrobials, but should capture all information about medicine. But also we have financial management module that should provide information relative to cash recovery, patient or insurers, or purchase orders and payroll. This can help just to estimate the financial burden as in the following slide. In fact, having this information can just contribute to have observable outcome at the time of data generation without going back to collect the data. It is also permitting to extend use of AST and AMU. AST is antimicrobial susceptibility testing, and AMU is antimicrobial use data. Then smooth, continuous improvement. Observable outcome, we can say about antimicrobial resistance data relevance. That is, if the standards are implemented in our tool, our data is compliant with standard and reliable. That is, we are just moving from the limitation we stated at the first slide. AML data accuracy, because they are constrained to implementation of the standard, but also accessibility, because we don't need repetitive work to go and collect the data because the data is already there. Antimicrobial rules, because the prescription is just electronic, and whatever you need in terms of variables and attribute relative to antimicrobial prescription, from the prescription to the delivery or to the use can be tracked, and then the financial burden. If this is implemented, we have the clinical, public health, and managerial decision-making improved. When we say decision-making, we are beyond just having decision-making in terms of guideline, but decision-making in terms of support. That is, a guideline is a written, but a support is a constraint from the written just statement. Yes, no problem. So extend use of this data is just beyond the clinical or this decision support, but beyond that, we can use the diagnostic data beyond the direct patient management, the clinical data, beyond direct diagnosis, patient data beyond direct patient management, pharmacy data beyond direct patient medication or prescription, and cash recovery just beyond counting money. But we can use this data in research and publications and have solution to contribute to continuous improvement. Sorry. So as extend use of AST and AMU data, we shall move from that limitation to a country like this, where the burden, we know the burden by data, just by having our accurate data of what the magnitude of the problem. That is clear, data-driven understanding of IML challenge specific to our own country. And we shall have the empowered initiative to effectively address the challenge we know, not the challenge others are telling us, because we need to know, we need to know it by data. So in terms of continuous improvement, we have the antimicrobial stewardship program that need continuous improvement, that managerial review and revision of rules and regulation, therapeutic review and revision of treatment guideline, but also prevention review and revisions of IPC rules, guideline, and regulation, but based on our data, on what we can do, not based on others' sayings. But also the tools that we are implementing need to be continuously improved. Not suggesting registers and forms in paper, but just thinking digitally. You need something to capture data, just discuss with IT people and propose solution that should capture reliable, accurate data at real time. Then, if there is a new functionality needed, especially for those who are implementing open source, this is in fact the base of just recommending open source solutions. It is just the ease of customizability and change. Then writing requirements relative to the standard. Then issue reporting if functionality are not in compliance with expected, and then bug corrections. So for currently in our country, the health management information system we have is based on DHIS2. This is a Java-based program that captures all information about our health problem. So it is open source, that is, it is customizable on whatever we need. It is extensively configurable, easily expandable, and we have IT people that have expertise on it. They are called Rwanda, and it is already used by the government for the collection of aggregated data on the health problems, and also integrate now, currently, it integrates standard on antimicrobial testing. These are Breakpoint, CLSI, and UCAST, and we used it to collect data from some of hospitals that are retrospective. So as you can see, this is based at the national level. So this data were entered using the form for data entry, but also it has an expressive and configurable dashboard with customizable layout and widget, dynamic data visualization, and an interactive filter and drill. That is, if this is used at our respective institutions and these data are captured, they can be visualized at real time. But because we have other systems, it is somehow difficult because by now we need to have a double data entry where we have limitation in our electronic medical records. Next, please. Ah, good. Oh, good. Thank you. So in our medical records, I'm sorry I'm going to use as a demo the medical record we are using at our hospital, CHUB, CHUB, which is open clinic. It has a prescription form like this, but it has this limitation and need to integrate the local and international treatment guidelines. This is from just entering a prescription, but to have a decision support relative to guideline, and monitoring and feedback like de-escalation, a recommendation about antimicrobial, and restriction if an antibiotic is restricted to be prescribed by some people and not others. These are minimal integration that need to be integrated in this system just to comply with IMS action. So on laboratory information system, in fact, this is the form that most of institutions using the same tool have, and this needs to be also upgraded to comply with testing standards, that is UCAST, CLSI, as far as data management is concerned. And these are elements that should be implemented. This is breakpoint integration that provided by standard, method, if it is MIC or DD, the panel, not just having a panel like this. In fact, if you see, idea. If you see jam 1 and jam 2 and jam 3 all share the same number of antibiotics. Yet we have jam 1 E. coli, jam 2 Staph aureus, but also we have strep pneumonia, and they share the number of antibiotics, the same number of antibiotics. Yet the antibiotic to be tested should be customized relative to what isolate is. So these need to be also upgraded. So at our institution, I mean CHUB, to share the experience, we made improvement of this form just to integrate this element, just to show you that with the software, we can think to improve our data management and just comply with standard and just move from the limitation to solution. Act now. This is the form now. Instead of having Escherichia coli and Staph aureus having the same number of antibiotic, so we need just to configure antibiotic we have, and relative to breakpoint, you have to this or that isolate, you will have a panel specific to that type of isolate. Not only that, some isolate has what we call expected phenotype, which can be explained by intrinsic resistance or maybe known susceptibility to some antibiotics. So with this, in fact, you don't need to test for diagnosis. Just you tell the clinician that this isolate, it is known to be resistant to this antibiotic without just doing this AST. Also, some antibiotic can have different behavior relative to whether an antibiotic will be provided intravenous or will be provided per oral. That is, a lab scientist can just report that this antibiotic, if you provide it per oral, it is resistance. But if you provide it per IV, it is going to be effective. But also some antibiotic represent others. That is, if I test ampicillin, you know that whatever I provide as a result to ampicillin can be inferred to other antibiotics like here, piperacillin and amoxicillin. That is, if you test amoxicillin and ampicillin and they have discrepant result, you know that you are wrong. But also what we call cascading, that is, if you have low-level antibiotic that are susceptible to isolate, you don't need to tell the clinician that this high-level antibiotic is also susceptible. Just at the testing level, you see everything, but at the right, the clinician see only low-level antibiotics. That's to promote de-escalation. If at the empirical treatment he provided a very high-level antibiotic, he should or she should de-escalate. Also, for analysis, we have a tool that proposed by WHO called HUNET for antibiogram report. So we also have to comply with export that can be integrated or analyzed in this HUNET. So as you can see at this field at the left, all variable exported from our improvement are in line with the variable proposed by HUNET. So as conclusion, we advocate for all institutions, I think it is even possible, to integrate interoperable standard AML data management into eHealth tool nationwide. That is, wherever the prescription is done or wherever AST is done, to integrate this standard, just to have reliable and accurate data. Also to educate, implement a holistic, data-driven pre-service, in-service, and community education on IMR. Not that because others say it, but we know the burden and we educate based on what we know as proof. But also act now by implementing a comprehensive AML surveillance program and respond to any resistance trend by our own data. This is the reference of my presentation. Thank you very much.
Thank you so much. He requests if there are some questions, but I think the questions will be after. Okay. Join me again to thank Dr. Jibril for a good presentation. It was very good and very difficult to understand, for sure. Yeah, we jump in an amazing session, a panel discussion with a theme, interprofessional collaboration for effective antimicrobial resistant control in Rwanda. We have different panelists, and moderator will be Professor Nadine Urugeni, who is an associate professor of microbiology and parasitology at the University of Rwanda, College of Medicine and Health Sciences, with extensive expertise in microbiology and public health. Prof. Urugeni is leading academic committed to advancing health research education in Rwanda. We are honored to have her guide today's discussion. You're welcome, Professor Urugeni Nadine. Let her props to, and she will introduce our panelists.
Thank you very much for the introduction. Good afternoon, everyone, and thank you again for your time and for staying with us the whole day. So this afternoon session, as she introduced, is going to be about interprofessional collaboration. And we focus on the misuse of antimicrobials, like we've been stressing since this morning, and also because it's one of the drivers, or one of the key drivers of antimicrobial resistance. So today we are with the panel members from different sectors, because we understand the importance of integrating different sectors, the human sector, the animal sector, the agriculture and environment. And all these panel members are also part of the AMR technical working group, and they contributed also to the development of the national action plan for AMR. So the discussions are going to be centered on 5 critical areas. The first one is surveillance. How do we enhance surveillance? Antibiotic or antimicrobial stewardship, infection prevention and control, public-private sector collaboration, and policy implementation. So I'm pleased to invite panel members. I'll be calling them one by one and introducing them. The first one is Dr. Isabel Mukagatare. I don't know if she's still around. Okay, so she's been replaced by Dr. Gahamanyi Noel. He is the division manager for the National Reference Lab at the moment, and he's a microbiologist. Specialized in bacteria infections, I think. He has experience in bacteria infections, control and surveillance. So the second one is Darius Uzabakiriho. Is he still around? So he's from the National Pharmacy Council. He's a senior pharmacist and health systems strengthening expert. He's the Chief Operations Officer and co-founder of Irebe Biotech Limited, a pharmaceutical manufacturing company in Kigali, in Rwanda, and a board member of the National Pharmacy Council of Rwanda, with prior roles in health system analysis and pharmacy regulation. Darius is also a PhD fellow at the Rwanda Biomedical Center and the University of Liverpool, focusing on advancing pharmacy practice and health systems. Thank you very much for being with us. Munyanganju Jose Edouard from the Rwanda Food and Drug Authority. He is the Regulatory Ecosystem Strategy Division Manager, and he holds a bachelor's degree in pharmacy and a master's degree in pharmacology, bringing over 16 years of experience in developing pharmaceutical supply chain systems and regulatory frameworks that ensure the quality, safety, and efficacy of pharmaceutical products. He's also the national focal point for antimicrobial consumption surveillance in Rwanda, playing a pivotal role in advancing the fight against antimicrobial resistance through strategic policy implementation. Thank you very much for being with us. Next is Dr. John Baptiste Muranga from the Rwanda Medical Association. He is a senior pediatrician and neonatology consultant. He is currently serving as the president of the Rwanda Medical Association and the director of medical services at King Faisal Hospital. And he has over 12 years of experience in clinical, public, and community child health. He plays a crucial role in mentoring neonatal teams across several districts, hospitals, and contributes significantly to national and international technical working groups on neonatal and child health. Thank you very much for being with us. Dr. Lorien Hamugabumwe, Veterinary Counsel. He is a veterinary doctor with extensive experience in Rwanda's government livestock sector. He holds a master's degree in veterinary medicine. He serves as an assistant lecturer at the University of Rwanda School of Veterinary Medicine and as a district animal resource officer at the city of Kigali. Thank you very much, sir, for being with us. Next is Dr. Taufik Adegboyega Tope from the University of Rwanda. He is a lecturer and a researcher in the Department of Microbiology and Parasitology at the University of Rwanda. And he holds a PhD and brings significant expertise in antimicrobial stewardship and antimicrobial resistance surveillance. Next is Dr. Mariska Kruger from King Faisal Hospital. She's a medical doctor from the Netherlands, specializing in tropical medicine and global health, with a master's in medical microbiology, with over 7 years of experience in Ethiopia and nearly a year in Rwanda. She is actively involved in clinical practice and research, aiming at improving the management of infectious diseases in resource-limited environments. Last but not least, Jean-Claude Rukundo from the Rwanda Agriculture Board. He is a senior veterinary program research specialist at RAB with over 14 years of experience. He focuses on veterinary products registration, AMR in animal resources, and antimicrobial residues in food products. He is Rwanda's WOAH national focal point for veterinary products and AMR, an active member of the One Health initiative. So thank you very much, panel members, for your time. I hope you all have a seat. So like you've heard, we have really a mixture of background and different sectors represented here. And I have a few questions for them, general questions, and some specific questions for different sectors. But I'm hoping that you have even more for them and more practical questions that are going to help us understand how best we can tackle the misuse of antimicrobials in different sectors. Okay, thank you very much. So the first question, or the first two questions, are going to be open to everyone, so everyone has a say on these questions because they are relevant for all the different sectors. But I would ask the panel members, so whoever is speaking after any speakers, please only add what you think has not been covered. So the first one is, what are the collaborative measures that you think can be taken to strengthen integrated surveillance systems to monitor and control AMR more effectively? So anyone who would be willing to start?
Okay, thank you. I'm the next to you, so I will start. So the question is, it's like, what are the collaborative measures that can be taken to strengthen the surveillance? The first one, Dr. Jibril already has mentioned it, using electronic systems. And better to have an integrated electronic system, better, preferably one. If not one, at least see how the existing ones can be interoperable. So the data from one sector can be exchanged with another sector. The second one is about the technical working groups that we are having. We should be meeting regularly, and also our decisions should be communicated in form of policy briefs so that they can be interventions. Also, you cannot start the surveillance with all the pathogens. Better to start with maybe one or two. A panel of antibiotics we should do tests so that once it is effective, we can extend to others. Thank you.
Thank you so much. In tackling this issue, which you have been saying they are silent, we need also to find strategies that are not commonly known. And I would like to say that this issue of AMR, most of us health professionals, we understand them into forums, and we have never seen maybe possible impact, yet the impact is very huge. So the collaborative efforts is to go beyond the health sector and engage other sectors and engage also the community. That's what I think, and it's really very important. If we are talking about AMR, we need to emphasize that we need to complete the course of treatment, and with a reason why that can be understandable by the whole society. Thank you.
Yes, thank you very much. I agree with my two colleagues. I think I want to commend first the leadership, RBC and colleagues who have done this. Why I'm saying this is because back in 2015, there was an attempt to develop the first national action plan. And it took 4 to 5 years to have the first national action plan. So what I'm commending today is that we did not wait another 5 years to review the expired national action plan. And this collaboration mechanism that needs to be commended. And back to what Darius was saying, different sectors were represented. So I think the governance structure that is emphasized in the National Action Plan, it has to be really well structured and well implemented. So the governance structure that represents all the sectors, human, animal, environment, all the sectors, but well represented and everyone contributing at the same level. I think that would be a key of implementing what we are saying. Thank you.
Yeah, thank you, Prof. I think with all the others have said, one of the key important things we need to be honest with ourselves and discuss is the issue of acknowledging the role of each other. We all know the barriers. If I'm a clinician, I tend to think what I decide is enough. And the pharmacist has no say about my prescription. And the goes the other way. Occasionally, the pharmacist feels what's the best in that field. And this is a huge barrier. So we need to have the minimum humility of understanding the law and respect of each other, and understanding that if I prescribe, there is somebody who knows better. And if we accept that and we have corrective measures, it will give room for collaboration and more dialogue around the issue. The second point that was mentioned is really breaking silos in terms of how we engage in this issue. Can we have joint CMs? Can we collaborate on research projects? Can we have more of collaborative interventions and everybody trying to bring, especially the professional associations? How much does the Medical Doctors Association dialogue with the Pharmaceutical Association, dialogue with Veterinarian Association? So to take this far, we need to a little bit do things that we have not been doing more. And the rest can talk about into that. Thank you.
And maybe, thank you.
Okay,
Maybe
thank you very much.
Sorry, just to kind of update a little bit the discussion. We've talked about sharing data or availing data in different systems and how systems should be interoperable. If we can hear from people from the agricultural, the animal sector, what systems do you have and can they be interoperable with the systems that we use in the human health sector?
Yes, thank you very much. In the agriculture system, we have, for the moment, we have 7 systems for disease. We finally decided to use the EIDSR because we have actually adapted it to veterinary use, and then we started just using it in July. So that has made it 3 months that we are using it. Let's say that we are at the beginning, but it's promising. Now we have almost 416 people on the system, but people who are reporting are not yet do not fully meet our expectation. Another thing I want to add is to consider case of resistance as a unique cases. They have to be given importance. I think that each resisting case should be reported and eventually shared across the sector. You may have a resistance in the human, but maybe you have the similar resistance in animal. So by sharing that data, you can even search further to know whether there are no similarities or any other related issue. Another thing I want to add is that we have heard this morning that the MR is a silent killer. It's a little bit like tension. So it's important that we break that habit of not speak a lot on MR. I think MR has been spoken, but do we really target the real or the right people? Maybe. Are we tackling enough decision makers, political makers? Maybe. But I think we still have a lot to do in terms of awareness. And other things that I would prefer that we should let figure or number speak. I think they speak louder than words. If you show each year that we have, maybe, it's just an example, we have 1,000 of people died because of lack of right antimicrobial, then maybe you may have another sense. So I think by capturing or generating those data and they let people know them, especially those guys who take the decision, it can bring a change. Thank you.
You can go ahead and maybe tell us how you think we can integrate the One Health approach into antimicrobial stewardship.
Yeah, if I may add something on the One Health approach and also give an example from the Netherlands, where I'm from. Once you have the surveillance data, what we do in the Netherlands is to combine it in a report. So both the animal and the human part is all combined, the antimicrobial resistance, the antibiotic usage in the different sectors. And that's very helpful for all the sectors to understand the burden of the problem and also to create early warning signs. And it's open access, that's also very important.
Thank you very much. First, I would like to acknowledge the roles of the government of Rwanda through the Ministry of Health and the RBC and other partners for the recent needs assessment that was done, as well as the gap identification that has now been incorporated in NAP2. In addition to what has been mentioned by my colleagues, is that there is a need, and as a responsive government, the University of Rwanda, particularly at the College of Medicine and Health Sciences, have also seen the need to develop specific programs and new curriculum that are quite very important in tackling some of these challenges of antimicrobial resistance and antimicrobial stewardship, right from the undergraduate students in medicine, dentistry, pharmacy, nursing, and other allied sciences have been introduced to the concept of AMR, AMS, particularly in modules that are related to the two concepts, microbiology 1, microbiology 2, among others. It's also very important that stakeholders also take into consideration that we can't work as an individual. It is often said that a tree can't make a forest. So there's a need for every person involved to work together in the concept of the One Health in stimulating desired goals. Part of what I think can also strengthen our capacity is to adopt newer detection strategies. We need not rely on culture-based techniques. There are newer molecular high-throughput sequencing methods that are available. And luckily for us in the country, we all have the platforms. So part of what we all need to do is to strengthen the needed human capacity to be able to use these platforms as the need arises. I also like to add that there should be a reward system. When the DG was speaking, he highlighted the need for appropriate investment. So I think we also need to indicate that at every quarter, from 2025 to the end of the execution of this NAP2, or for the first year, is it possible for us to reward healthcare workers or providers? Is it possible for us to reward communities based on the reports that we receive at the end of each quarter? So that can also assist to simulate the needed education that we need in reducing the burden of AMR and increase AMS. Thank you.
We can also reward best practitioners in terms of how many antibiotics they prescribe or how many effective antibiotics they prescribe. Yes?
Yes,
okay.
Exactly, ma'am.
Okay, thank you. I would like to add two things to promote like One Health in the AMS. First of all, we should have a clear aware classification where we have access, watch, and reserve. So some antibiotics should be really reserved for specific cases, not only in humans, but also in the livestock. And also the same antibiotics, sometimes they are misused. So some antibiotics, maybe very particular to humans, can be used in the livestock, but with restriction. So the other point I wanted to mention, it's like dispensing antibiotics only with prescriptions, or antimicrobials. We are talking about antibiotics, but including other antimicrobials, where pharmacists, not only in humans, but also in the veterinary field, they should give antibiotics on prescription. That would help. Also, the clinicians, as my colleague was saying, antibiotics should be prescribed with some evidence, and also start from the low level. Even the empirical treatment has some guidelines. So start with the low level before going to the broad spectrum antimicrobials.
Okay, thank you very much. I also want to highlight the crucial role of veterinarians to contain IMR because as WHO representative said, vets play a crucial role in animal disease treatment, and they mainly use antibiotics. They also have a big role in inspection and control of quality of animal products. So another very important point is they also use it to sell those medicine to the farmers. And there is a need to pay attention when prescribing, that's one, but also provide such antibiotics when it is needed. The vets, in vet medicine, they said protecting animals is protecting public health. So we all used it to eat meat and milk, and you can imagine if a vet can deliver or can approve such meat or milk for human consumption while it contains the antibiotic residues. So we have a lot to educate the farmers when we are treating their animals, highlighting that we need to respect the withdrawal period. So different kind of antibiotics, they have different withdrawal periods. For example, for the milk, even for the meat. So we have to educate farmers in that way. So to strategize or to incorporate this IMR issue into One Health approach, we realized that when developing the national action plan, we realized that most of the sectors and the stakeholders, they are represented. But when we go to their institution, you realize that they don't have this issue of IMR or One Health approach in their annual work plan. And this brings a challenge to the One Health Secretariat. They might miss who to contact, who is reporting such intervention. We have many young people here who have a very innovative initiative, but they are lacking coordination, and sometimes they are also lacking support. So they need to be involved at the policy level, that's one, and also during the implementation. Thank you.
Thank you very much. We've talked about prescription, the use and the misuse. So this brings me to the next question that probably is the Rwanda FDA and Pharmacy Council are most concerned. How do we implement, or how do we execute the policies and the regulations that we have around antibiotic or antimicrobial use? So basically, how do we make sure that someone like me does not go just to the pharmacy and buy antibiotics or buy half a course of an antibiotics? And how do we make sure that in animal sector, these antibiotics are the ones that should be used, and making sure that the ones that should not be used are not used?
Thank you. I will speak as a regulator. Then I think my colleague Darius will speak about the profession, because that's what they regulate. So as a regulator, you are really concerned by two things. Is the quality of the product, the quality, safety, even the efficacy of the product, including antibiotics. But you are also concerned by the rational use of these antibiotics. So what we do to ensure the quality and safety, we have regulations, guidelines that start from way the product will have applied for marketing authorization. And when the product is being sold on the market, the post-marketing surveillance, import and export control, and so even the use. So we have regulations, guidelines, and everything that cover that part. But when we're talking about the rational use, we also work with our stakeholders, for example, the Ministry of Health, because they help us, they develop the essential medicine list, for example, that are needed. And I think when they're developing these essential medicine lists, they take into consideration the country situation, the standard treatment guidelines that are developed into the country. So all those are tools that are needed to help prescribers, even those who are dispensing those products on the market. So our role is really to work into enforcement, in developing, availing, and enforcing these regulations and guidelines.
And what are the main challenges that you encounter in enforcing these regulations?
So the main challenges, obviously, is to assure the quality of those products. You were challenged by a substandard falsified product, for example, that we have on the market. And this is a global issue, for example. And a lot of information from even the WHO is coming, telling you that in our countries, low and the middle income countries, you have like 10% of the product that are circulating on the market, which are substandard or falsified. And these are the main substandard falsified main drivers of antimicrobial resistance issues, because those products, what they do, they don't kill the microbes. Actually, they make them even stronger. So this is our big challenge, and that's what we need to work on.
Thank you so much. I want to say that at the National Pharmacy Council, our main role is to ensure that wherever there is a pharmaceutical product, there is a drug and drug molecule expert who is a pharmacist. That's where we start with. So where at least there is a pharma product, there shall be an expert for pharmaceutical products. That's our first role we play. Then once we ensure that whoever is to be called a pharmaceutical scientist or a pharmacist has the prerequisite to be called the so. The prerequisites are of three categories. Number one is in terms of knowledge. For anyone to share with us, the profession has to have at least the minimum knowledge and has to be an ethical practitioner and eager to learn more. So our role basically is to ensure that whoever with those skills is practicing in an ethical way. And we are encouraging the member of the public that whenever you see anything that is deemed non-ethical, please report to us and we shall be taking adequate measures. We recognize that drugs themselves or drugs are poison. We do recognize as a pharma expert that the only thing that differentiates a drug with a poison is the dosage. And the dosage is not only 500 mg, is to continue the treatment up to the end. So we are doing our efforts to have ethical practitioner. And as you asked to my colleague of Rwanda Food and Drugs Authority, you may also acknowledge that our profession has three big pillars. And the pillar number one, of course, is the pharmaceutical science. The pillar number two is the health practice. And number three is business. So we act as the interception to keep the balance, that our pharmacy practitioners could always stick to health profession, and our primary role is to protect the public. Thank you so much.
Thank you very much. I think someone in the morning asked the question of ethics for the pharmacists, the issues they have. This is open to anyone. The issues of being ethical when actually you're winning your bread. I mean, if you have a pharmacy and next door there's another pharmacy and next door there's another pharmacy, if you don't give them these antibiotics or these antimicrobials, the next pharmacy is going to give them and their business is going to flourish and yours won't flourish. How are the pharmacies regulated? How do we even have a regulation of how many pharmacies per kilometer square or meter square that we should have in the country?
So we don't have those. How many pharmacies must to be in one area,
in a sector or in a
district,
district,
or in a setting? But we believe that when the regulations and the practice is well enforced, if the regulations are well enforced, there will be no problem. We know there is a challenge of people who think that pharmacy business is a lucrative business and who do not consider that like a professional. But if it's well enforced, we believe that those will just go out of that business and let the people who are working professionally do what they're supposed to do. So we do our part, and the Pharmacy Council is doing their part, and we see a lot of changes in that sector very soon.
Okay. Yes? Okay. You want to?
I just want to add a very small thing. As a profession, you know, we have something called social contract, which is a contract we have with the society. And we as pharmacists, most of the time in a pharmacy you may find other cadres and who may act differently and reflect the image of all of us. And in a forum like this, we can't stop without advocating to increase the number of pharmacy professionals. So our call is to universities. We need to train additional cadres. And when I talk about cadre, I'm not talking about those only with a bachelor degree. I'm talking about those with an advanced level to phase out non-pharmacists who are already in our pharmacy. I'm talking about those with specialization who will be able to generate data to inform the policy. Thank you so much.
Thanks a lot. Yes? You had an addition?
Just more comment on the question, but as now a professional user, to be honest, I think we still need to add in our regulation. The regulation that we use do not precise exactly how we should deal with antimicrobials. They just speak about products in general. It will never tell you that you cannot have an antimicrobial at the pharmacy without any prescription. It will never tell you that, neither in the law or order or guidelines. So we think it's very critical to have tools which are strong enough to limit that practice. For example, if I need an antimicrobial, I can go easily in the pharmacy and get it. Whether in a human pharmacy or veterinary pharmacy, actually any farmer somehow can get access to the antimicrobial for animal, which most time bring abuse of those products. So we need strong text which limit access to antimicrobial. Another thing I want to emphasize on is the inspection. How can we make sure that people who are in the pharmacy really follow the rule, what can prevent them from selling those antimicrobials to anyone? So we need something really actionable, something really strong enough to limit that. Another last point, I think, which can bring a solution, maybe we need to think about how to have an electronic prescription tool, so that anything that the doctor or a veterinary doctor prescribe, we make sure that it is the only thing which is served in the pharmacy in terms of antimicrobial. That I think if ever we reach it, it can be a very big achievement. Thank you.
Yeah, thank you very much. Now let's talk about the IPC, Infection Prevention and Control. We know we have some strategies and control programs for different infections, especially the vaccine preventable infections. But we also have, we know that at the hospitals there are a lot of infections that are acquired. What do you think are the challenges that we have that are remaining for effective prevention, tracking and reporting of these nosocomial infections or infections acquired in the healthcare setting? And how can we integrate, or how are they integrated with the control programs for other diseases?
Yeah, thank you. That's the big elephant in the house, especially when we are dealing with a situation after recovering from the Marburg outbreak. Really, challenge number one is behavior and attitude. Just as the AMR partly is caused by all of us neglecting it. There is, Jibril talked about reading an article and then you interpret it from the writer's perspective and not owning it. And sometimes that's a big challenge. The reason I'm saying is that we are very fortunate as a country, as a system. We have the basics of tools. For example, if we say King Faisal Hospital, I will let the technician talk about that. We have PPs, we have alcohol gel, we have tools, basic tools to use. If they are used effectively, then we should be able to control much of the transmission of antimicrobial resistance, microbes from one person to another, from one patient to another. But because of partly the attitude and behavior of not really taking it seriously sometimes contributes. Absolutely, there is always a question of continued capacity building, knowledge sharing, and having the CMEs to reinforce the knowledge and the skills that are optimal so that we optimally handle the infection prevention and control. Our infection control committees, which my colleague Mariska will talk about, but I wanted to now move from there. We talk about the issue of how we dispose the things we do that are also part and parcel of contributing to the spread of those microbes, and where, especially in the environment that we deal with, that is more difficult strategic issues on national level to really harmonize how it does. But to summarize, if we have like 70 or 8% of the basics we need if we effectively utilized them into that perspective. Yeah.
Thank you. Any addition?
Okay, thank you. In addition, it's about like the DG mentioned in comparing NAP1 and NAP2. So there's a need for a very strong will and capacity to ensure that every level of healthcare providers adhere to the protocols that are needed in managing hospital-acquired infections. Also important is to ensure that the tools, the digital tools that are being rolled out, as well as all existing tools that are needed for data capture, are used adequately for optimum reportage while we are scaling up, improving all the necessary platforms, so there is a need for the actual reporting to prevent underreporting of all the cases that we may be experiencing. Then that's also touched down to the concern about infrastructure, that there is a need to scale up all the necessary infrastructure, PPE, consumables, and the likes that are needed to ensure that we reduce the burden of hospital-acquired infections. And of necessity is also to enhance the delivery for WASH. That is key. It is not only when there is an outbreak that will bring it back. So before we don't pray for any outbreak, but it should be like a consistent practice in the community, at homes, and every level where there is human and interaction to ensure that we have a very safe and healthy environment. Thank you.
Yes, to add on the comments of my colleague, human behavior is always difficult to change, not only in Rwanda, and IPC needs a kind of ownership, and it's always challenging to create that ownership. So sometimes you need the tools and also certain restrictions or obligations to make people report. I would also advocate for uniform definitions of hospital-acquired infections. There are uniform definitions, but I'm sure that different hospitals might report certain situations in a different way. And then when you have the data on hospital-acquired infections, giving feedback to the departments. Thank you.
Thank you very much. Just one last question about public-private partnership. How do you think we can optimize this public-private partnership to boost interdisciplinary research and development into developing new drugs, vaccines, other biologics like diagnostic tools? How do you think in our settings we can boost this partnership between the private and the public sector?
Okay, thank you very much. I would like to share with you about the model the Ministry of Agriculture and Animal Resources is implementing, which is known as veterinary sanitary mandate. This is a formal public-private partnership whereby the veterinary practitioners in a district will organize in a company and will sign a contract with the district to deliver some of services the government used it to deliver on behalf of the public. And also the earmarked fund come to the district will use it to pay that private company. So we moved that way. We realized that in our context, 88% of veterinary practitioners, they are in private. It might be quite different with our colleagues from human sector, and that's why the government realized that 12% remaining cannot serve the public as good as possible. So with that model, the company can have an access to the government facilities as well, because they now have the contract. It will be easier for the follow-up, and it will also improve the service. So the government will also keep playing the role of overseeing the service, monitoring and evaluation, and also help the private sector in resources mobilization. And that resources mobilization will be a tool to implement the public health service and also There's also a sharing the laboratories. This is very important. I remember when COVID pandemic came, 2020, I was in Nigeria, and there were also a lockdown. And when the people started taking samples, they realized that the laboratories for human sector, they are not enough. So what they did, they worked together, as we are emphasizing, as we are advocating to keep working together. Then the veterinary laboratories, the veterinarians, they were given just a small training, because the science is the same. So if it is a PCR, if it is ELISA, what a human doctor, what a vet doctor can do it. So they used vet infrastructure to curb the pandemic. They shared the workforce. I think if there is a way to formalize this kind of public-private partnership, it can be possible. We have some of the examples, and it is also recommended to run from the other countries, to share the best practice and also to learn what they did better than us. Thank you.
Thank you very much. Thank you very much for your kind attention. Now it's time for a few questions from the audience, if there's any. If you have a question, you can just raise your hand. Do you have a mic? Thank you. I think that we can have a couple of 3 questions.
Thank you very much. I'm called Nadia Uwera. I'm a veterinary doctor by background and public health practitioner, and I work with Rwanda Food and Drugs Authority. So my question is about representation of sectors. We have seen it in different presentations that the environmental sector is still, the representation is still low. And if I have heard well, even the panelists that we have there is no person from the environment sector. So I was wondering, I was worried, and as we are talking about interprofessional collaboration, I'm asking why is the representation of environmental sector still low, and what are the strategies that are in place to increase that representation? Thank you.
I think that we can have all questions together. Even the previous presentation, if you have any question about it.
Thank you very much. My name is Sylvester Iradukunda from University of Rwanda, Pharmacy Department. I got one question. I want to address to Dr. Gahamanyi from RBC. How are you planning to engage youth or young people in addressing antimicrobial resistance? As you know, young people are like tremendous resources for change, for education, for advocacy, and different action. Is there any plan to engage young people in this strategy of combating antimicrobial resistance? Thank you.
Another question. Yes, as there was some question to Dr. Jibril, if I don't.
So thank you so much. First, I'm starting saying thank you to the panelists and the moderator. I think that while they were calling everyone, I was like, wow, this is one of the biggest panel we are having. And we are having one of the good one. So thank you for everyone. My first question, it seems that the main cause of MR, if you was following the presentation, it was like pharmacists the main cause. But really, if you are on the field, you know that pharmacists, maybe we are there, we are contributing, but very little. So my question was that I learned in school that before prescribing any antibiotic, the antibiogram should be conducted. So I would like to ask people from medical association, our physician, are you following that rule? Before we be the cause of the MR. So my second question also, it is to Dr. Kruger. I know that you know that for us in the field, we could be listing 2 or 3 points that are contributing to the MR in our settings, but can you please share your experience where you are having the standard of care, where you are having the laboratories at every corner, and what is really the contribution? What is the MR in your country? Where are you having the gaps? Thank you.
Thank you so much for the question. Let's first have answers. If the time allows, we have other questions after. Let me take this.
Thank you. My name is Charles Kayumba. My question is a very simple one. I want to know who our target groups to educate and advocate, because you have to be, we have got to be very specific to know which target groups and what are the strategies to reach those we are targeting. That would answer the whole question. Thank you.
Thank you so much for the good questions.
Okay, thank you. I'll go first. Yeah, the question about the representation of the environmental sector. Maybe I didn't cross-check if there are representations. If they are there, maybe they can raise their hands. But we have been involving them since the project of revising the NAP. There were not many. At the start also, they didn't know it, but we had to train them, to sensitize on what is AMR, so that when they go back to their, let's say, their bosses at the Ministry of the Environment, at least they could understand. So there is a trend that is changing. We hope that they will be involved during the next phases of the implementation. For engaging youth with Sylvestre, yeah, it is being done, maybe not at the maximum, but and I really congratulate the youth, because when we started the WOW, World Antimicrobial, it was a World Antimicrobial Awareness Week, 2020, 2021. So the NGOs with Laurier, so there were a few groups that we worked with to start these activities. So I really congratulate you, and what do you do? We notice them going to the radio, having campaigns to the hospitals, to the community. We really see it, and we really appreciate. So Gashegu is here, the director of One Health. Please remember to include them in our activities, even our technical working groups. Yeah, I have seen Oasis, so they are even represented here, which means that something is being done, and we will continue to advocate for the involvement of youth, because you are really a resource that should be utilized to the maximum. So the last one who was talking about that, the pharmacists were appointed as the source of contributing to MR. Anyway, because you are also contributing, not the main, and if you are aware, around 70% of antimicrobials are used in animals. So already it shows that you are not the first contributor to the issue, but you have a big role to play to curb this trending of AMR. In dispensing antimicrobials when they are prescribed. I was talking to my colleague, Prof. Rujeni. Sometimes we also forget leftovers. The antibiotics we use in our homes, where do they end? So regulators also better to start thinking about it. What is the fate of the antimicrobials that are not utilized into our homes? Thank you.
I want to make a contribution on the question the contribution of pharmacists to AMR. And I want to say, if we start like this, the whole conversation we have been having would be worth nothing. If we start from the discussion we obtained from the representative of World Health Organization, he reiterated that this is an issue of the whole society. And here in a scientific fraternity, we could not blame each other. We could potentiate the issue and find together a solution. And the solution, as it has been mentioned, is none than anything else apart from One Health approach, which is a holistic and a societal approach to tackle the issue. And we don't have to ask if doctors are following their protocol or not. There is an issue, and the issue deserves a solution, and the solution is One Health approach. Thank you.
Thank you. Just quickly, I want to respond to the question of Nadia. She was asking why we don't have people from the environment. I was just joking with a colleague here that this is a question from the MCM coordinator. So it's I think we have a coordination mechanism, and the leaders of the coordination mechanism needs to make sure that everyone is represented. And very quickly, for the question about who is the target audience, I think it's everyone, because we just realized before we realized that even the National Action Plan 2.0 that Prof. Muvunyi has presented, few knew about that National Action Plan. So we need this knowledge about the National Action Plan. It can start by the professionals. The professionals then can even share or advocate to the wider audience or the wider population. So we need health professionals to be aware that this is existing, that the collaboration mechanism is important, that we have all these activities in the National Action Plan that they need to implement, and then we have to reach out to the entire community because it concerns everyone.
Yeah, thank you, colleague. A very quick answer to the question, but I have a suggestion for the organizers. The next year theme, we will write "Leave no one behind." Instead of educate, advocate, and action, we will say "Leave no one behind." I think it concerns everybody. So yes, the principles, the rational principles of prescription is that we have to be guided by a number of things. Clinical and laboratory support, especially the culture, sensitivity, and testing, which, as I mentioned, we have privilege. That is part of the infrastructure that is developing fast in our healthcare sector. And I think perhaps Dej talked about it, but much as it's not scaled up to every health facility the way it's wanted, but it's the infrastructure is progressively and rapidly being developed. Nonetheless, that gives the room that occasionally we are forced to prescribe based on the clinical judgment. And in that context, again, there are very clear guidelines, there are very scientific rationale on which you base to make a prescription of antimicrobial, even if you were not able to do culture, sensitivity, and testing. So you will see, colleagues who are here, you will see a number of prescriptions that are not necessarily guided by sensitivity testing. In addition to that, we do what we call empiric treatment. Empiric treatment simply means if you come, you have fever, I think you have an infection. The culture and sensitivity testing we have will take about not less than 48, 72 hours. So we cannot wait until then. We rationally, based on the clear knowledge and understanding, you prescribe antimicrobial based as you wait for the culture and sensitivity. So to summarize is that there will be incidents where we prescribe without sensitivity testing, but we also, the ministry and RBC, they are rolling out the necessary infrastructure to make it feasible to be guided by the sensitivity testing. Thank you.
Thank you so very much for, yes? Okay.
Okay, thank you. I wanted to compliment Dr. Gahamanyi about the youth engagement. Maybe to formalize this resolution, 2022, the FAO, UNEP, World Organization for Animal Health, and the WHO, they have launched youth engagement in IMR. This has been done after realizing that the youth, they have high number, and also they have the powers to change, to bring the change in the society. So when we come to Africa, we used to have the Africa CDC Public Health Conference, and also they have the youth pre-conference. So what we can advocate simply is, as he said, for the next year, the youth who are in this room will be happy to have a kind of youth pre-conference, because we also in Rwanda, the population, the youth also is the majority, and most of them don't also have the information about the drug use. So I think it will be one of the way to engage and also support their contribution. A few weeks ago, as he said, they have engaged the Continental online campaign. And I'm happy that such initiative comes from Rwanda. It is the young people from Rwanda who mobilized the youth across the continent to join a such campaign on antimicrobial resistance. So the DG is here, and they said Dr. Gashegu, and we should not worry about our representation from the policy level and the implementation. Thank you.
In brief, in addition, is that microbes are ubiquitous. So they are found everywhere. So those that are to be educated and to receive advocacy are everywhere. In addition to that is the role of education is also very key and important, right from undergraduates and postgraduates. And like I mentioned at the UR College of Medicine and Health Sciences, this is key and pivotal in responding to the need to the AMR and AMS. In addition, is also the media. So there is a need for effective use of the media, electronic, print, and others in this campaign. We can't do it all alone in this room. So there is a need to extend our reach to the various media outlets we have in the country. In addition, is the community is key. We have been speaking a lot of scientific language or terms. There is a need to go to the marketplaces, to go to the bus from Uye to Kigali. I address issue in the bus about AMR, AMS. If I'm in the market to buy my fruits or grocery store, I speak about AMR, AMS. There should even be a calculated attempt. Like we see the campaign on tobacco and tobacco use everywhere. So we can also adopt such a strategy as a means of informing the minds of the population about AMR as it is important. We go to religious and worship centers. These are places where we have large people and the leaders of such community can speak to them once they are educated. So we really need to step down all these activities to the community level to ensure that we have optimum delivery. And like I also suggest, we need not to wait till WOW 2025. We can bring down the MIE to a quarterly level. From January to March or April next year, where are we? What have we achieved? And we continue to go in the line of improvement. Thank you.
I think there was one question for me and about my country, but I can rephrase it a bit broader. So the question was, if you have actually all these regulations in place, maybe regarding animal transport, animal screening, environmental screening, pharmacies are working well and are not dispensing drugs without any prescription, are there still gaps? That was the question. And yes, the numbers are maybe better in certain countries, but not zero. And we have especially seen that during the inflow of Ukraine refugees, that suddenly the numbers came up. I think we sometimes tend to forget that life expectancy has changed. We use a lot of immunosuppression, chemotherapies, and all these things trigger more infections and also give us the need that we have to treat these patients with antibiotics or antimicrobial therapy, and that's also one of the driving forces.
Yes, thank you very much. I want to comment on the intervention of a young gentleman behind there and the senior gentleman here. I think it's about education. It's about education. First, we cannot engage this combat or fight without youth. Youth, tomorrow, they will be decision makers. Youth, they are prone to be convinced easier than old people. Youth also is very dynamic, so I think they will have a big role to play in the fight against MR. But also, our action for the youth should be mainly in education. From low age, start with small kids and educate them so that they grow with that well understanding of MR. Most of people today have not really captured what is the resistance for antimicrobial. So maybe they are in the position of decision making, but they need more information. They need more figures. They will need to really understand what actually is in the game. So they need to be advocated so that the decision be favorable to the MR fight. Thank you.
Thank you very much all for your contributions, and thank you very much for your attention. I think one last homework to give to you all with regard to who to educate and how to advocate and who to teach. I think it's a homework for all of us if we can look at our institution, our action plan, our performance evaluation, and make sure that we all put something with regards to AMR. I think we will achieve more. Thank you very much.
Thank you so much, panelists. Join me to give a big applause to our panelists. Thank you so much, all speakers, all panelists, for sharing their expertise and insight us through different presentations and discussions. Ladies and gentlemen, esteemed guests and participants, as we draw this conference to a close, it's my great honor to invite RBC Director General, Dr. Claude Mambo Mvunyi, to deliver the closing remarks. Please join me to welcoming DG to the stage.
Thank you very much, the moderator of session of this afternoon. I'm not sure if this is the right thing to do as a closing remarks. I think if you consider from this morning, my task is going to be very easy in many ways. First of all is that I just want to thank everyone who has participated in this conference, which is only one of the activities that we think could be part of this awareness week, which I think for us is not only awareness week, but it's a week where we take serious actions. That's why today we have seen the launch of this National Action Plan on antimicrobial resistance. So thank you very much for each one of you to have stayed till the morning. I can see that you are still alert, following the discussions. Thanks to all panelists, moderators. I think the sessions were very fruitful and also very attractive for many reasons, because antimicrobial resistance is one of the key global issue, global crisis. And Rwanda, as you all say, Rwanda is going to take the lead in terms of making sure that we protect our nations, our communities, as we educate them, educate ourselves, but also continue to advocate in whatever capacity we have at the respective sectors that we have. The One Health that we mentioned today, I think, is also going to be a very key component of what we want to take from this conference. So again, thank you very much for each one of you for making this conference a success. I just also wanted to thank the organizers. I think let's really give them a round of applause. I think the beautiful of the rooms, the sessions, I think they are a team that is behind the organization of this conference. I think I want just to have them stand up for recognitions. I think the team, RBC, our partners, Rab, Gashegu, I think was the lead, my office. I think let's really thank them. I think they have really worked very hard behind the scene to prepare this conference. Of course, I just want also to thank also one of our partners, Chris from Birmingham University, who for many reasons coincide with his visit in Rwanda, and then is also one of the good advocates of antimicrobial resistance in UK, but also in Africa. So thank you very much also for being with us in these sessions. All our partners, I think, thank you very much. I think this is also an activity that was also supported by generous support from our partners. We have mentioned, we have them on the here, but again, there are also other partners who also supported us. There's also other associations, councils, pharmacists, students, I think also. Thank you very much for being with us in our effort to have this day a success. So again, for anyone who is here also, let's give applause to everyone to being here from the morning until this morning. Second, I think RBC, Rwanda Biomedical Center, we know that we do implement a lot of interventions. I think the panelists have mentioned a lot of interventions or ideas on how to simply act on one thing. How do we reduce the misuse of antibiotics? I think if you leave this room with actions, without forgetting many things, all activities which are in the National Action Plan, but how do we, at our respective stations or work, how do we make sure that we reduce the misuse? And when I say misuse, I think all sectors understand very well what do you mean by misuse. And if really we have this as a takeaway actions, Rwanda Biomedical Center will be able to work within the One Health sector, multi-sector coordinations, to really be able to bring everyone together. I also like the recommendation of having a M&E framework, which is start now. I think we don't want to have this national action plan in our shelf or in our office. Let's really have it like a live document. And as I said, when we come back here next year or next time that we have a review of these implementations, at least we'll be happy to reach 100% of implementations of these action plans. This is, I think, something we need to take as actions from this conference. Again, as I say, RBC will continue to reduce or to prevent infections because any opportunity for prescriptions is also an opportunity for misuse. So that's why we need to make sure that we have a good program for vaccination, for example. How do we make sure that all our children receive vaccines to prevent infections so that we reduce the opportunity for misuse? Second, I think working with WASAC and also other sectors, how do we make sure that we have WASH, hand agents, IPC, so that we also prevent transmissions of infections, which I think, again, reduce all those opportunities for misuse of antibiotics. So we are going to make sure that we support you reducing occasions for misuse, but again, when it comes to prescribed antibiotics, because we can't avoid prescriptions, but let's make sure that we have the right prescriptions, the right patient, right doses, when needed, right time, and avoiding side effects, but also resistance. So I think if you leave this room with this, those few definitions of antimicrobial stewardship, for me, I think antimicrobial stewardship sometimes become very complicated if you don't really break down of what are the interventions that at all levels we need to do to reduce misuse of or inappropriate use of antibiotics. We've mentioned about regulations. How do we use a pharmacist to educate patients or the community? How do we reduce the demand for antibiotics from the communities? How do we make sure that we don't be in a situation where a mother who does not come out from the consultation with antibiotics is considered that is not really treated? So again, it requires time for educate, and we're not going to educate today only. Let's continue to educate patients, educate providers as we do our daily work. Again, the fight or the journey does not stop here. When you say antimicrobial resistance awareness week, we are on Friday today, and I think the organizers of this week all over together, we want you again to be with us on Sunday, where we'll continue to raise awareness, and we'll have a very good day with making sure that we work with the community. We give messages to say, yes, help us in protecting the few antibiotics that we have so that we still remain with available antibiotics which are still effective. I always say that probably each one of us will be at a certain time be eligible for antibiotics. So I don't want you here in 10 years to come or tomorrow, you'll be in hospital without any effective antibiotic to treat infections. Our parents, our families, I think maybe they're in hospital where there's no available antibiotic because of just our behavior and how do we misuse antibiotics. So if you really take that message, educate ourselves, educate others, continue to advocate. We have to be convinced when we educate. And then for ACT, yes, today we have those commitments. I hope that we'll continue to have a summary of these meetings. I think the team has been taking note. We hope to get some good recommendation from this conference. But again, I hope that you commit to be together on Sunday during the car-free day with with all the voices that we want to make sure that the community is really aware of the issue, but also they also know how to support us in our fight against antimicrobial resistance. So again, thank you very much for all of you for being today. This is a journey that's continuing now, start now. Let's move from this room with those concrete actions, recommendations, how that all of the things we discuss here did not remain in this room. So let's really carry those recommendations and discussions in our respective day-to-day work as prescribers, but also as garant of the community and so on and so on. So thank you very much again to everyone for being here today. And we'll meet again on Sunday, continuing this awareness so that we conclude the week with really a good voice on antimicrobial resistance. Again, I can't finish this closing remarks without also thanking the Minister of Health, RBC, but also the government of Rwanda, because the government of Rwanda takes seriously the health issues. And they all know that IMR is something in the commitments or in the political decision, political wills, I think it's there. It's just all up to us to use that opportunity to come up with solutions, to come up with actions. And then when we come back here after 1 year, we'll be happy to see that what we discussed today is really bearing some fruits as we expect. So again, thank you very much. I wish you enjoy the rest of the evening. And also we meet again on Sunday. Until then, let's advocate, educate, and also act now, just now, and then continue to act. Thank you very much again for your kind attention.
Thank you, Sam. Well done. Well done. Appreciate it. Yeah.
It's a hard job you just did.
Thank you. Appreciate it.
I wouldn't have done it.
Dufate ka cyayi tuhita tugaruka.